to a sort of broader population context, last year there was 160,000 deaths in Australia. About 120,000 of those were reasonably predictable. People died of conditions that might have been anticipated within the last 12 months. Half of the people dying predictable deaths in Australia are living in residential aged care at the time of their deaths, although many of them don't die there, they're transferred to hospital to die.
And that, of course, raises a whole separate question about the provision of palliative care in residential aged care facilities.
But if you look at that population, you're talking about a very frail population who are very vulnerable, and that physical vulnerability then creates a lot of fear and distress.
It may be of assistance if we went to the next slide, the using slide at point 0112.
This slide is using, as part of our assessment, looking at the help that people in residential aged care need in terms of basic self-care tasks, bathing, dressing, toileting, grooming and eating. For those basic activities of daily living, 80% or more of residents need help. A bit over 2/3 need help with eating, but it's 80% in those other areas.
Yes. And without necessarily going to each of the slides, the key message here that emerges from the studies, as I'm understanding your evidence, is that this is a typically very frail cohort with significant care needs across a range of daily living activities.
Absolutely. And the other thing I would say about it is that this is a cohort who are so frail, they need time with those activities, that when staff are rushed, it increases the risk of injury, falls, pressure injuries, skin tears, and it also increases the risk of distress.
If we can take a simple example that we've heard many times during the Royal Commission, if a shower is rushed, the care worker providing the shower may miss the signs of an emerging pressure sore.
That's right.
And it may be then sometime before it's realised, by which time it becomes particularly difficult to treat.
That's right. And I think the other issue I would raise is that when staff are rushed, they don't have the conversation with a resident about their appetite for risk, and they don't document it. So that is, it takes you now a long time to get dressed. Would you prefer me to help you, or would you prefer to do it yourself? What is your choice?
Yes.
And we should be having those conversations. That's part of the dignity of risk.
Commissioners, I'm about to go on to a new topic. I was wondering if it might be an appropriate time to have a morning break.
Desirable. 10 minutes?
Yes, sir.
Adjourn for 10 minutes.
All stand. The Royal Commission is now adjourned.
Thanks, Mr. Rosen.
Thank you, Commissioner. Professor Eager, we had reached a point before the break where you're explaining the outcome of the RUC studies, noting the high degree of frailty of the residential aged care cohort. And what I would like to do now is move to the work that we've asked you along today specifically to talk about, which is a more recent report that you have done for the Royal Commission. And that report, if it could be brought up, is behind tab 148 of the General Tender Bundle, Exhibit 11.1. And that's the report that has recently been completed by the Institute under your directorship.
That's right.
And as we can see from the title, it's how Australian residential aged care staffing levels compare with international and national benchmarks, a research study commissioned by the Royal Commission into Aged Care Quality and Safety. And it's only very recently published. In fact, it's only published on the Commission's website at this point. Is that right?
That's right.
Can you tell the Commissioners a little bit about the background to this, please?
When we did the RUC study, we collected really good quality data on staffing levels and mix, and that gave us really a very rich data set, which is one of the problems in this sector is the absence of data, but allowed us then to do an international literature review looking at the evidence on countries that had either ratios or standards for staffing, and then to compare Australian data from our representative sample with the international evidence. We deliberately selected countries that had systems that are comparable to Australia, and we did that work just over a couple of months.
Okay, we'll come to the detail of that in a moment. Just to provide us with a bit of context, the report sets out at page .0007, if that could please be brought up, there's an introductory section, and I want to ask you about the paragraph that appears at the bottom of that page, if that could be highlighted, please, the changing policy context. And we can see there that you're noting that with the introduction of the Aged Care Act 1997, there's been a philosophical repositioning of the sector. Can you expand on the significance of that for the report?
I think it's a really important issue. There has been a philosophical repositioning to describe residential aged care as a person's home, and none of us have a problem with that, and to describe a wellness approach and a social approach, and none of us have a problem with that. I think the problem arises when those sorts of conceptual ideas and policies and philosophies have become a justification for inadequate care. And both in terms of the type of staff, the skill mix of the staff, and the adequacy of staff numbers. And our contention, which I'm sure we'll get to, is that residents have a right, and it is possible, to provide both an environmentally friendly place for people to receive care, socially engaged and clinically competent care at the same time.
Yes, we will certainly come back to that. If we go to the top of the following page, please, which flows from the observations you've made that I've just drew your attention to, and if the top paragraph could please be highlighted. You say there, this reconceptualisation of residential aged care as a home has inadvertently encouraged the development of a workforce that is less clinically skilled and oriented with greater reliance on lower skilled personal care workers. Similarly, there's been limited incentive for either government or the sector to invest in systems that routinely capture and monitor resident needs or outcomes over time. If I could deal with the first sentence in that paragraph, please. Why do you say that the reconceptualisation has inadvertently encouraged the development of a less skilled workforce?
Because when people have described residential aged care as a person's home, it is somehow implying that it's a lifestyle choice rather than people are going into residential aged care now because they are so frail or have other significant care needs that they can no longer be at home. The population currently in care needs more clinical skills, not less.
Can I just ask you about that? So it's a case of the homeliness aspect of it not being added to the services, but rather a taking away from the services that had previously been there. Is that how you see
Yes,
it
I
happening?
think that's fair. I think prior to if I go back 20 years, homes were criticised because they were institutional. And this was a whole policy shift to say, let's move away from an institutional model and a feel and make them more homely. But I don't think anyone ever intended that you would move away from a clinically competent model towards more of an unskilled model. But that is actually what's happened.
And the data which you summarise on the next page of the report, page 9, in table 1, at the bottom of the page, if that could be highlighted, this data makes that point, does it not, about the changing nature of the workforce?
That's exactly right. That the workforce has, over time, there are now less allied health professionals, there are less nurses, both nurse practitioners, registered nurses, enrolled nurses, all qualified nurses,
Yes.
and more staff with minimal training.
And that's not just a relative difference, that's an absolute difference. In other
There's an
words,
absolute difference against a backdrop of the sector growing quite remarkably over that. If you worked it out as a ratio, it would be even worse.
so it's not that we are adding to the institutional care the homeliness that we need, it's that we are actually reducing the professional staff and putting in people who may or may not be able to give the homeliness aspect of it.
That's absolutely right.
You note in your examination of the relevant literature and this is at page 10 of the report, .0010.
Just before you do, sorry Mr Rosen.
No, that's fine,
I
Commissioner.
do apologise to interrupt you, but maybe some of you are going to ask anyway. Is the driver for this a driver to provide homeliness, or is it an economic driver about returns on investments?
I think the driver was actually economic, but it was also a driver from consumers that they wanted a more socially engaged, a less institutional, a less patronising model of care. So I think it's a combination, but I think it's been an unholy set of interests that have come together to have a de-skilled workforce, and I'm not sure that consumers would actually believe that the workforce has actually given them what they wanted when they wanted a less institutional feel.
Well, presumably the consumer didn't want a reduction in the other services. They presumably wanted something on top of.
That's exactly right.
But it's the reduction of that I'm asking you about. Is that economic, or is it because there's some other driver that...
Oh, I think the reduction in health professionals has been largely economic.
The evidence we've heard, and you can tell me if this is consistent with what you're now saying, Professor, the evidence we've heard is that residential aged care facilities where there are few nurses may be more inclined to send out a resident to be treated in an emergency department of a public hospital. So in a sense, the cost is shifted in those circumstances to the public health care system. Is that relevant to what we're talking about here?
Absolutely.
Yes.
If a home does not have either the numbers or the skills to care for residents, the easiest thing to do is to call an ambulance and transfer that person to an emergency department.
Yes.
And one of the major data failings in the system is that we do not have accurate records about the number of people who are transferred to hospital for basic care needs and also at end of life.
Yes, we've also heard evidence of that in this commission. If I could turn, sorry, Commissioner Piccone, does that adequately address that?
Yes,
questions?
it causes me to think of other things, but I'll come back to that later.
That is your prerogative, I must consent.
Well, if there's a need, so if the shift results in it being easier to call an ambulance, does that mean that the decision to do that is based upon inadequate consideration? That is to say, if the person deciding, oh dear, I'm not sure what's happening here, I better call an ambulance, rather than I'm trained, I can deal with this internally, I don't need to call an ambulance, I can deal with it. Does that mean that one is getting too many calls for ambulances where they're not needed?
There are too many calls for ambulances where people could have been cared for within the home without going to hospital if better skills and better staffing had been available, including reports of people dying in the back of an ambulance because nobody recognised or had the skills to care for people literally in their last hours, days and weeks.
Thank you.
If we can skip forward in the report then to page 15, please, where you set out the methodology that you followed to reach the conclusions that you did. I might just ask you if you could please summarise the methodology that was followed.
The methodology consisted of an international literature review looking at the evidence around staff ratios, and essentially that evidence says there are two ways to deal with this issue. One is minimum staff ratios and the other is to define appropriate staff ratios.
Yes.
We then looked at comparable countries to Australia and we initially identified about a dozen.
Could we go to the table on page 17, please, operator? That might. I'm sorry to interrupt, Professor.
And they're the countries that we initially looked at.
Yes.
The US, Canada, UK, Germany, Netherlands, Japan, New Zealand, Australia. We then went through and started to look at their care systems, and we eliminated those countries who had different systems where you couldn't draw meaningful comparisons. And the two obvious ones to highlight there are New Zealand and the UK, because on most measures we would compare to those two countries, but they have maintained the distinction between high care and low care. And so whilst they do have minimum staffing ratios and standards, they're not directly applicable because we have merged those two sectors.
If I could just interrupt there, that's a distinction that existed in Australia prior to, I think, 2014.
That's right.
And saw the sector divided, as you say, into two quite distinct groups, which have now been brought together in
That's
Australia.
right.
Sorry, I interrupted you. So that was the exclusion of New Zealand and the United Kingdom. The other exclusions, Japan, the Netherlands, and the Canadian provinces, what was the basis for excluding them?
That we were not confident that the people in those residential aged care facilities in those countries are representative of residents in Australia. And that's partly around the range of community services that are available in countries. The countries we selected have pretty well developed community aged care facilities, and also reporting that people now going to residential aged care are a lot frailer and a lot higher need than they were years ago.
Ultimately, you chose as comparators the USA, Germany, and the province of British Columbia in Canada.
That's right.
And we note from that table that there's a reference up the top left-hand corner to United States Medicare, Medicaid. Can you assist us there? Is that a particular subset of the United States aged care sector, the Medicare, Medicaid sector?
Medicaid, Medicare are the federal and state systems in the US.
Yes.
And if a home wishes to receive government subsidies either through state or federal, that is pretty much every home. There are a very small number that are private,
Yes.
and then they will be part of that system. There are about 25,000 homes in the US who are eligible for who registered for payments under Medicaid and Medicare.
Okay. So for practical purposes, it's the US
Absolutely,
aged care system
it
that
is.
you're looking at. Yes, I understand.
And the international review, were there constraints about language?
We only reviewed papers in English and in German.
So the Japanese one was available in English,
in English.
but presumably there would have been a number of European countries that didn't have material available in English.
That's right. There's also work on staff ratios done in other countries. We recently reviewed a paper from Korea, for example, but it was actually in English. A lot of academic papers internationally now are in English, irrespective of the primary language of the country.
And the reason you're able to look at German papers is you have a staff member who's German
A
speaking.
health economist on our staff is German.
Ultimately, the study focuses on the USA as the best comparator, although you draw on aspects of the British Columbia system, as we'll see in a moment. Why was that? Why was it the USA that was ultimately chosen? It's somewhat counterintuitive because one hears a lot of negative things about the USA health system.
I've been a very loud critic of the American healthcare system, but on this occasion, I think that we do have lessons we can learn from America. America started doing research looking at the relationship between staff levels and resident outcomes back in 2001.
Yes.
It adopted a national system back then. It has maintained research every single year, and it updates the results of that research every year, so it's contemporary. There are 25,000 homes who are funded under those arrangements. It is so well established in the States that nobody even questions it anymore because the evidence is so strong. The other thing that's really important is that it does adjust for the mix of residents, and that for us was one of the essential criteria for selection. The other issue for me, which I thought was important, is that it doesn't just address minimum staffing, it also addresses appropriate staffing.
I was wondering, Professor, if it might be of assistance to go back to your slides at this point of your presentation, and correct me if I'm wrong, but I think the slide at point 0117, this is tab 150, please operator, it's page .0117.
No.
No, just back a little bit from there. So .0117, please. Perfect. What's the CMS star rating system? What's that an acronym for?
The CMS is the Centre for Medicaid and Medicare Services in the US. It's an overarching part, a very well established part of the Federal Department of Health, and it does a lot of work regulating standards and services, not just for the federal systems, but for all of the states in the US as well. It runs a public reporting system called Nursing Home Compare, and any member of the public can log on to Nursing Home Compare and look at the homes that they're interested in and look at how they compare. And rather than trying to work through screeds of text, those really complicated and very sophisticated rating systems are synthesised down into 5-star rating.
If we go to the next slide, please, on .0118.
There are 3 domains that are reported publicly in Nursing Home Compare, and one of those is staff hours. So it's a measure of inputs, and it is adjusted for the mix of residents in each home. The next measure is a process measure. So for them, that's inspections. It would be accreditation in the Australian context.
Yes.
And the third are quality indicators, which are resident outcomes, adverse events, but also some quality indicators, such as, for example, the percentage of residents who've been immunised or vaccinated for flu. That, again, is case mix adjusted.
I could just ask you to pause there for a moment, Professor. So one can go onto the Nursing Home Compare website. Any of us can do it if we've got access to the internet, and we can see a rating system that is based on data from each of those three domains.
That's right. And you can limit your search and say, I want to look at the nursing homes, the US nursing homes, within a 10-kilometre radius of where I am.
Yes.
And it will just show you those homes, or you can do it for the whole country, if you 25,000 homes if you want.
Yes.
And that is updated every year.
Okay. And is it done? Are the comparisons in the rating system state-based or are they national?
They do both. So first of all, they calculate national rates, and then they do some recalibration for public reporting, because if you're in Alaska or Hawaii, you actually want to know what the range is within the jurisdiction that you're likely to be wanting to select from for consumer. So there's two sort of purposes. One is public reporting to allow consumers to make choices, and the other is for accountability.
Now, for the purposes of this report, you've primarily focused on the first of those inputs, that is staff hours, first domain, staff hours.
Yes, if I was to adopt this sort of system in Australia, the bit that's missing, and it's my last dot point, is if we were to really move towards a balanced scorecard, I would also want to add measures of consumer and carer experience.
Yes.
Because that is the missing element. But for the purposes of this analysis, we focus solely on staff hours.
If we can then go to the next slide, please, .0119.
The weakness of the American system, and we'll come back to it in a while, is that allied health is missing, and I'll come back to that. On the staffing side, though, it gives a 50% weight to registered nurse minutes per resident day and a 50% weight to total staff hours per day.
And just so that we're clear about that, a calculation is made of the hours or proportion of hours of total care time, whether it's provided by a nurse or a care worker, to use the language that we use in Australia.
Yes, total care staff hours in the American system, they will describe it as nursing hours, but they don't actually mean a registered nurse in the way we understand it. And that includes the registered nurses, but is not limited to them. We mapped each of the professional categories in Australia to each of the professional categories that we were doing the international comparisons with.
So the nomenclature in other jurisdictions doesn't entirely line up with ours.
That's right.
But the functions performed by the particular people in those descriptors can be compared to...
Yes, and in some cases we also had to go back and look at primary training and requirements. For example, how many years of training was required to say that a particular category of nurse was equivalent to a registered nurse in Australia.
Or an EN, for example.
Or an EN.
Yes, I understand. Can we go to the next slide, Professor?
This is the minutes per day, and this is what you see in an appropriate care system rather than a minimum staffing system. For each of the two main axes, registered nurses and all care staff, CMS define 1 star according to the number of minutes, and I'll just give you an example, right through to 5 stars. For registered nursing, any home providing less than 19 minutes a day, it gets a 1 star. Between 19 and 30 minutes gets a 2 star, right through to 64 minutes and plus gets a 5 star.
So I can just pause you there for a moment. So this is not a system that says a particular facility has to provide a certain number of minutes per day.
No.
This is a system that measures what's actually provided and then allocates it a rating according to this matrix.
That's right, and homes are required to submit their payroll data.
Yes.
It's not a separate report. Each month or quarter they're provided to actually submit their payroll data, and their staff time is calculated from their payroll.
Right, and that's the source of the data that makes its way into the rating system.
That's right, and the other thing to say about that is that whilst it's 19 minutes this year, for registered nurses it might not have been that last year. These thresholds are regularly updated in the light of the changing dependency profile of residents and industry standards.
Yes. You have in fact provided us with a document just yesterday which makes good that proposition, and I'm busily trying to find it. Do you know what tab number that is? No. Just excuse me a moment, please, Professor. It's tab 201 in the general tender bundle. I'll just ask that to be brought up. And perhaps if the top part of that could be highlighted firstly, please. That is table 4. And perhaps it might be simpler to go to table 5 first and we'll do it chronologically. Sorry, operator, if we can go to the bottom one. Staffing points and rating updated April 2018. What are we looking at here?
So if I just give you an example, for 5 staff for registered nursing in 18, that was defined as being equal or greater to 0.88 of an hour, 88% of an hour. We need just to be careful, it's not minutes, it's fractions of an hour.
I'll just pause, I'll just interrupt you there, I'm sorry, and just so that we can all understand this, because you and I have spent probably more time looking at this than perhaps others. On the left-hand side of the matrix, we've got a heading RN rating and hours.
That's right, and that's
And
the
then
rows.
And we go down there, we can see rating 1 is the equivalent of less than 0.246 of an hour. Mm-hmm. So it's slightly under a quarter of an hour. Round figures, we're looking at about 14 minutes or somewhere in that
19.
vicinity.
19. Oh, yes, it was 14 or so last year, yes.
Last year, yes. And so what that means is that if focusing only on the registered nursing minutes for the moment, if you've got less than the 14 minutes or thereabouts, that's a 1-star rating.
That's right.
But of course, the American system is not only concerned with the time spent by registered nurses, it's also concerned with the overall time of care that is
That's
provided. Right. And so we need to look at the columns as
well.
And we see the heading there, total nurse staffing rating and hours. And that's a little bit confusing because it's not just nurse time, it's a combination of RN, LPN. What's LPN?
Licensed practice nurses. Right. And what the US are calling a nurse aide is what we would call personal care assistant.
Yeah, so that's the
so
total.
It's total care staff.
Yeah.
But it is a bit confusing because I use the word nursing.
Yes.
But it really reflects a culture that this is about providing nursing care.
Yes. Okay. And then without going through each of the columns, we can see that the star rating, be it 1, 2, 3, 4, 5, is contingent on the amount of time, the total staff rating hours. So a rating of 1, if one is focusing only on the total number of hours, is anything less than 3.176 hours.
That's right, and I think we'll see that later in one of my slides that might be clearer at illustrating that.
Let's do that. So I just wanted to make the point here, if I could, that picking up on your comment about the flexible nature of the ratings, that it's updated on a yearly basis. If we look at table 4 at the top of this page, we can see the figures for April of this year, and these are in fact the figures you've used in your report, aren't they?
That's right.
And we can see if we just concentrate on RN rating and hours level 1, that's gone up in that year from April 2018 to April 2019, so it's now 0.317 hours, increased from what was previously 0.246
That's
hours.
Right.
So that's where the 19 minutes comes in.
Yes, that's right.
And are you able...
Can I ask just why would that have gone up between years, just so we can understand?
Because they're also collecting data on the care needs of residents in a quite extensive minimum data set, and also changing. So if the care needs of residents go up, then the care hours go up. So even though this methodology was designed back in 2001, these thresholds are continually revised to reflect the changing needs of residents. And if we adopted a system like that in Australia, we would equally need to do that.
Thank you.
And it's collecting the changing needs of residents by reference to what they're actually getting. But
also what they need. The sort of assessment that we did in the RUC study, where you saw some of the figures, that sort of assessment is a mandated part of the reporting system.
Thank you.
And if I'm understanding this correctly, these figures are the product of a very large amount of data that comes in.
That's right.
About care needs and actual care provision, and that data is crunched and produces these
That's
figures
right.
ultimately.
And it's regularly updated every year.
Yes, as you've explained. All right, thank you. If we could then leave that document and perhaps go back to the slides behind tab 150, and I think we had got
20.
to slide 120. Here we've got those same figures that we were just looking at for April 2019, but instead of being expressed in fractions of hours, we've got them expressed as minutes. Why did you make that change?
Just because it's too confusing for everyone to look at fractions of hours. It's easier to convert, and we've done that all the way through the reports. We've converted everything to minutes.
Yep. I think you started to take us through this table, and then I distracted you by dragging you back to the other one. So if we can go back to this one.
The evidence out of the US is that each threshold, each step up, has evidence for better outcomes. And the 5-star threshold peters out because they could not demonstrate any better outcomes at another higher level. And that's really important, and why I think it's a better system, although not incompatible with minimum staff levels. There are 2 statistics, I think, of interest on this slide that are really important. The first is the bottom part of that, the bottom row. For all care staff, you get a 1-star rating if you provide less than 186 minutes of care. The Australian average is 180 minutes. So for all care staff, Australia rates 1 star. For registered nursing, which is the other 50% in the waiting system, the Australian average is 36 minutes of registered nurse time, and that rates as a 3-star, where the range for 3-star is 30 to 44 minutes. There is one caveat I would like to put on that. Our study was necessarily quantitative. We were looking at the total time available rather than what is done in that time.
Yes.
We have ample anecdotal evidence that registered nurses are spending a disproportionate amount of time on paperwork for ACFE, for accreditation and for other administrative requirements. And if you took into account the amount of excessive dead wait time in administrative requirements, I suspect that the registered nurses wouldn't come anywhere near 3-star.
I should have asked you this earlier, Professor, but the 50% weighting that's given to registered nursing minutes within the overall score means that that's given a disproportionate status in the assessment. Presumably that's because that recognises the disproportionate, in a positive sense, contribution made by nurses to the overall care of people.
That's right.
That are
30
looked
minutes of
after.
registered nursing time is not equal to 30 minutes of a personal care worker.
Yeah, it's worth more, if I can use
Absolutely
a colloquial
worth
expression.
more.
Understand.
And costs more, but it's actually worth more too.
Yes. And so just going back to this comparison, am I understanding the point to be that on overall care minutes, by comparison to the United States, we do particularly badly in that we're 1 star on average, but if one focuses only on registered nursing minutes, we do better. We get to the 3-star rating level.
Do with my caveat
With the caveat, yes.
about what people do with their time,
Yes.
and with my observation that homes would need to spend more time on paperwork to be paid for a resident than a hospital needs to complete to be paid for a heart-lung transplant.
Yes.
When Commissioner Tracy and I have visited residential care facilities, they often say to us about 2 in every 4 RNs are spending their time on paperwork, and that's what they do all day.
Yeah.
Is that a common arrangement?
I think that is exactly common. I gave a paper last year at the Adelaide Conference for the Nurses Federation, and I was overwhelmed by the number of nurses who said to me that they had left the sector because all they were required to do was paperwork for income maximisation, ACFI maximisation, that they loved working with older people, and that they would come back into the sector if they were actually recruited back in to use their clinical skills to care for residents.
One hears the expression nursing the desk. Is that what we're talking about here,
I think
Professor?
so. I'm not a nurse, but I have great admiration for them, and I do know that we're not using them as well as we could.
So just for me to be clear, of the 36 minutes that Australia has for registered nurses, some proportion of that 36 minutes dedicated to a resident is actually filling out forms.
That's right. We don't actually know what it is. When we did the RUC study, we had the Department of Health had a expert stakeholder reference committee. They asked the representatives from homes what they estimated that to be. Their estimate at that was about 30 hours per resident per year on ACFI compliance.
Could we go to the next slide, please, operator? Point 0121. And can you take us through this, please?
So the American system puts those two components together. Registered nurses are the rows, and you'll see 1, 2, 3, 4, 5. 1 is less than 19 minutes, 5 is greater than 63, so it's exactly what you saw this time, though it's a row rather than a column. And the columns are total care staff, and the two of them are combined in the American system. And you'll see that one of those cells is in red, and that is 1 star for total staff and 3 stars for registered staff, gives Australia as a whole a 2-star rating. The other thing I would point out from this slide is that there are 25 cells, because it's 5 by 5, and there's only 5 stars, and there are different combinations to get you to each combination. We have said that 3 stars is the bare minimum for adequate care. There are actually 9 combinations that get you to 3 star. And this is really important because one of the arguments against ratios has been that this is a blunt instrument with a one-size-fits-all approach. This sort of system, which is more sophisticated, allows for homes to have a quite different mix of staff in each home, depending on the unique needs of their residents.
You're saying that 3-star is a bare minimum. Mm-hmm. So if you get to 4-star, what's again the total staff rating required in minutes?
4-star, and you can see in fact, it might be helpful to go to the next slide, I think.
It's
No, sorry.
it's slide point 0125, is that
25.
right? I think.
That's it.
That could perhaps be made a bit bigger on the right-hand side. That's it.
This slide's a little bit hard to understand when you first look at it, but it's the same idea. The registered nurse time are the rows, the total nursing or total staff time are the columns, the red cells are the 1-star cells, the green stars over at 5-star, and the yellow is the bit in the middle, that's the 3 stars. And the percentages in that table are the percentage of residents in each of those cells. I would also...
If I could just interrupt you there. So there are 9 ways you can get to 3 stars.
That's right.
They're the ones that are in the light yellow, if we can call it that.
That's right. So you can get to 3 stars if you have 4 or 5-star registered nursing, but only 1 star for total care staff, etc., right through to the other extreme, 5 stars for total care staff, but only 1 star for registered nursing.
And presumably that's because if we look at the top right-hand one, where it says 0.0%, that's 5 stars for total time and 1 star for nursing. Presumably the thinking there is that even if you have minimal nursing time, provided you have lots of overall time, then that balances out to some extent, gets you to 3 stars.
Yes, but I'll go back to an earlier comment, which is the Americans case mix adjust.
Yes.
So they would calibrate this for the unique mix of residents in their homes. And so if you think about the homeless facilities, the facilities that specialise in homeless people, their staff mix needs to be quite different from a home that has a lot of physically frail people.
Yes,
So as long as you case mix adjust,
yes.
this works.
And I should have asked you this earlier, but you spoke about the amount of time our nurses are doing paperwork. Is that something that's taken into account in the American system? So when they talk about minutes, is it minutes of actual care time by nurses?
No,
or
it's
is it?
also including clinical documentation.
Yes.
But I think our system, for payment purposes, is much more inefficient than the American system.
Right. Okay. So it's not. I understand you'd be saying that there's some paperwork which is absolutely vital to
Absolutely.
performing the clinical tasks, such as making records of the administration of medications and so on. But you're talking about paperwork which is unrelated to the actual care.
Paperwork
task.
for clinical purposes,
Yes.
to document an assessment of each resident, their care plan, the nature of the care that they've been delivered, any adverse events, quality problems, etc., is absolutely essential, and it is part and parcel of being a clinician. Every clinician does that and would not dispute the need to do that. I'm talking about the paperwork which is for administrative and funding purposes that doesn't add value on the floor.
Understand. And you were taking us through the table that appears on the screen, and those percentage figures are your assessment of the percentage of Australian residents in the study that fitted into each of the 25 categories.
That's right, and it's a percentage of residents, not the percentage of homes. And this goes back to the questions you asked me earlier about sampling. 1.4% of residents are in homes that rate 5 star for both total staff and for registered nurses. The other comment I'd raise, and I know the Nurses Federation is giving evidence on this, the Nurses Federation has developed a model, and when we mapped it to these standards, the Nurses Federation model is equivalent to 5 star for registered nursing and 1 star for total care, giving a 3-star rating.
And just so that's clear, that's the bottom left-hand figure. That is 5 star, it's 0.0% there, if that could perhaps be
That's
highlighted.
right. Yeah.
On the bottom left-hand
Oh
corner.
yeah,
of
there's
the
nobody
chart.
in that cell.
And as it turns out in Australia on your assessment, there's nobody actually
There's actually
receiving
no one in
level
that
of
cell.
care.
No one's receiving that level of recommended care by the Nurses Federation.
Okay, so there's two things there. If the Nurses Federation model was to be adopted and this assessment tool was used to assess it, that's where it would be at three stars, because it's 5 star on nursing and 1 star on total minutes.
But I'm sure the Nurses Association's not saying that you can't do better than that. I would highlight the 1.4% of people that are getting 5-star nursing and 5-star total staff.
Yes.
I would also point out that if you look at the totals for nursing, there are quite a lot of nurses, residents getting at least 3-star compared to total staff. So the bottom that you're looking at, 73%, 72.9% of people are only getting 1 star for total time.
Yes.
The spread for the registered nursing, which is the column that's now being highlighted, is actually much more even.
Yes. Thank you. We just go back back 2 slides to point 0122. In my file, I jumped ahead in the slides. Can you tell us what we're looking at here, please, Professor?
Yes, what we're looking at here is the percentage of residents in Australia and in the US who meet each of the stars. The pink colour is the profile of Australian residents and the blue colour is the American profile. You will see that the Australian homes are clustered much more down into the 1, 2 and 3 star compared to the Americans, which are much more evenly spread.
And this is where your figure of 57.6% of Australian facilities being 1 or 2 stars comes from. If we add together 11.9 and 45.7,
Yeah.
that's where that figure of over half of our facilities.
That's right. So those first two 1 and 2 stars together for Australia, and that is quite different to the percentages in the US, pointing out that the US system is not a mandated minimum, it's appropriate.
Yes. If we go to the next slide, please, 0.0123, this summarises the analysis that's included in your report.
Yep.
These terms, unacceptable and acceptable care, are they terms that are actually used in the CMS
No,
system?
they're our judgment as a research team.
Yes.
A couple of things. We actually made a call, a judgment, that is how we see the system based on our really considerable experience doing this work now over 25 years, looking at the relationship between inputs, outputs and outcomes in subacute and non-acute care, but also on the American evidence. The other thing I would want to say about that is that for simplicity, I've shown it on this slide as being 30 minutes of registered nurse time and 215 minutes of total staff time. But note there's actually different sets of combinations to get there. That's for each of them. But you don't actually have to have both of those. It's the combinations. But to simplify it, I've really used that as the proxy.
Yes. That's the 9 ways of getting to 3 stars that we looked at.
That's
earlier.
right, and I've just put one up here.
Now that slide, of course, is headed my judgment, and I should take you back now to your statement, if I could, at paragraph 43. So it's Exhibit 11.2, paragraph 43, which is on page 11.0011. And if we could just, if you can take us through, in summary, please, Professor, what you're saying here.
My judgment is based on 3 factors. First, I do feel qualified to make this judgment. I've been working in this area looking at the relationship between inputs, outputs and outcomes in subacute and non-acute care for more than 2 decades. My second piece of evidence around that is the significant care needs that I summarised before. This is a very frail, vulnerable population, 30% turnover each year due to death. The third is the evidence out of the CMS itself, who now describe the evidence on staff ratios and staff thresholds as being both strong and compelling. And this really disputes the other issue that's commonly raised in Australia, that there is no evidence for staff ratios. There is, according to the US, strong and compelling evidence for not only staff ratios but for thresholds. And the threshold between 2 stars and 3 stars is defined as the point at which under 3 stars you are more likely than not to have quality problems.
Now, paragraph 44, you make the point, I take it it's an important one, that this is not a set and forget system. Can you explain a little about what you mean there?
Yes, one of the concerns we have, given the lack of historic R&D, research and development investment in this sector, is that somebody adopts standards, sets and forgets them. The profile of residents continues to change and they're not updated. I pointed to the US, where there is periodic revision. I've also given another example in this paragraph. Our expert nursing panel raised the point about a new cohort now starting to present in residential aged care requiring bariatric care due to morbid obesity.
Yes.
This was defined in our study as people requiring 3 or more staff plus hoists and other assistive devices to move them. If the obesity epidemic that we're now describing at a population level turns out to be the case in Australia, we are going to need more and more staff to deal with that as resident dependency increases. The other thing I would say about that is that the more successful we are in providing genuine options for people to stay in their own home, the more the cohort who go to residential care will be extremely high need.
I understand that to be that this is only heading in one direction.
Yes,
in your
the
experience.
thresholds won't ever come down whilst people in our community want to stay at home and whilst we provide systems of support which allow them to do so.
Now, just to conclude, and I certainly don't want to rush you, Professor, and I'll give you the opportunity to say anything else that you want to say, but if I can go to page 12 of your statement, please, where under the heading Concluding Remarks, you note that the work was commissioned by, the work you've done has been commissioned by this Royal Commission, and you make reference to the evidence before the Commission in paragraph 53 to the effect there's a need for additional investment in care funding, the majority of which is required to improve the staffing mix and to increase staffing levels to an acceptable standard. It's the next sentence I want to ask you about, paragraph 54. You say, I recommend that increased funding be provided as one element of a comprehensive reform of the total aged care funding model. Now's probably not the opportunity to seek from you broader evidence about your ideas there, but are you able, in brief compass, to summarise them?
I would make two remarks. The first is that the ACFI is no longer fit for purpose, and so maintaining the current funding model but just throwing a bit more money at the problem will not solve the problem. We need reform, but it can be incremental over years. So that was my first point. The second issue is that one of the things that is missing in this sector is a policy on the relationship between cost and price. And by that I mean, if you think about the way residential aged care is funded, there's an accommodation stream, and there's a hotel stream, and there's a care stream. It would be quite reasonable to argue that government funding for care should actually be invested in care, and that care is not a profit stream. And if we had a system that ensured that all care funding was actually invested in care, it would be a very different sector. And I'm not commenting on accommodation and hotel costs, they're separate, but care funding needs to be thought of as part of a broader aged care funding model that also gets rid of some of the perverse incentives in the current funding model.
I think it's no secret that the Commission next year will be examining funding in considerable detail, and you may hear from us again at that time. Just putting you on notice. Commissioners, they're the questions that I have for Professor Eager at this time.
Yes, Professor Eager, thank you very, very much. It is quite an eye-opener to see the material presented in this form, and you've certainly caused me, at any rate, and I'm sure also Commissioner Briggs, to think about matters in a way that we might not have been thinking beforehand. I thank you for this, for your efforts, and for coming here today.
Thank you.
Professor Eager, be excused, please, Commissioners.
Yes, the good news is that you may go back to, to work.
And our next witness is Professor Hollairs. I call John Flair.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Professor Pelaez, can you please state your full name for the purposes of the transcript?
John Carl Polaers.
And Pelaez is spelled P-O-L-L-A-E-R-S?
That's right.
For the purposes of the Royal Commission, you've actually made a number of witness statements, and perhaps I'll just take you through those now to clarify the record. Firstly, is a statement that you've made dated the 20th of September 2019 for the purposes of this hearing. It's WIT.0361.001.001. That should be on the screen in front of you, with your date of birth discreetly redacted. See? Can you confirm for us, Professor, that that's the statement that you've made dated the 20th of September 2019?
Yes, that is.
And have you had an opportunity to read through that statement before giving evidence today?
I have.
Is there anything in it you want to change?
No.
Content's true and correct?
Yes.
Tender the statement of Professor Pelaez.
Yes, well, the statement of Professor Pelaez dated the 20th of September 2019 will be Exhibit 11-3.
Commission pleases. And without needing to tender anything further, but given that you're here, it's a good opportunity just to clarify the record. Way back in February, feels like a long time ago, you received a letter from the solicitors to the Royal Commission drawing your attention to some evidence that had been given by a witness, Mr. Versteger.
That's right.
Do you recall that? And if tab 5 of the documents already tendered folder could just be displayed, please. This is exhibit. Exhibit 164. That's it. Thank you. This has been received into evidence as Exhibit 1-64. If I could just ask you to confirm, please, Professor, that this was the response that you provided when invited to respond to the evidence given by Mr. Versteger.
Yes, that's correct.
Thank you. And then finally, you've been good enough to provide us with a response to the report prepared by Professor Eager, which we sent to you a little while ago. If tab 166 could please be brought up from the general tender bundle. And if you're able to confirm for us, please, Professor, that that was a written report that you provided to us in response to our invitation to you to comment if you wanted to on the work of Professor Eager.
Yes, that's correct.
All right. With that housework taken care of, can I ask you a little bit about your professional background, please? Professor Pelaez, you are currently the Chancellor of Swinburne University.
Yes.
We see this at paragraph 2 of your statement. I'm sorry, paragraph 4 of your statement, if that could be brought up, please, on page 2. You're also the Chairman of the Australian Industry and Skills Committee.
That's correct.
You're a member of the Aged Care Sector Committee.
Yes.
That's a role you've held since 2018.
Yes.
And can you tell us what the Aged Care Sector Committee is, please?
It's essentially a group that was brought together, I think, under the Labor government some years ago to provide advice to the Minister on issues associated with industry.
And you're a former member of the Aged Care Financing Committee.
Authority, yes.
Oh, sorry, Authority. That was a 3-year appointment which concluded last year.
That's correct.
In amongst all of that, you run a business called Leaf Independent Living Solutions. And what's the nature of that business?
Essentially, it's a business built on an understanding of the order of functional decline and then identifying product technologies and services that can help extend the independence of the elderly and the disabled.
And you've got an extensive business background, which I won't go into detail of now, but do you have any specific aged care experience that you're able to draw on?
Yeah, I guess at a personal level and at a professional level. At a personal level, my wife and I lost each of our parents to mismanagement in the system, 2 to medication mismanagement, one to misdiagnosis of dementia and another to frequent transfers to acute care. I also have a disabled sister who has a more disabled son, and I've been their guardian for the last 10 or so years. At a professional level, it's largely through the involvement in the government committees, obviously through the work of the task force, but also through the work of Leaf Independent Living Solutions.
I want to turn now to the work you did on the Aged Care Workforce Strategy Task Force. If the report of the task force could be displayed, please. It's tab 1 of the documents already tendered folder, and it is part of the evidence before the Commission. It's part of Exhibit 1-4. That's the front page, is it not, of the report of the task force, a matter of care. You chaired this task force. It's often referred to as the Polaires Task Force, but without asking you to be overly modest, it was the production of a committee, was it not?
Yes, it was.
And of which you were the chair. And your appointment was on the 14th of September 2017 by the then Aged Care Minister, Mr White.
That's correct.
And the task force itself was announced by the same minister on the 1st of November 2017. I think it's uncontroversial that the task force, the establishment of the task force arose out of an earlier Senate report, did it not?
Yes.
It was actually a recommendation of the Senate report, The Future of Australia's Aged Care Workforce.
That's
Is
correct,
that right?
as I understand, yes.
Yep. The terms of reference that the task force was given by the government are on page .0131 of the report, if that could be displayed, please. I think it's the next page, please. Okay. Sorry, I think we've got two versions of the document. So if we can, the version I'm looking at might be easier. It's acw.9999.0001.0131. Thank you. They're the terms of reference of the task force.
Yes, they are.
Without going into them in minute detail, can you give us an overview of what the work of the task force, what the task force was asked to do?
Yeah. Essentially, the task force was really attempting to deal with a substantial number of open issues resulting from very many previous reports that had touched upon workforce but hadn't actually addressed it. So the intention was to make sure that we looked at the current structure of the workforce, the changing nature of consumer expectations, and then the various models and responses to the issues that arose. They went to the areas of workforce planning, they went to the areas of supply and retention, leadership capability within the sector, education and training. And the brief was wide enough, if you like, to also enable us to look at interface with other sectors of the care system, to understand the funding needs and requirements developing over time, and to look at this in both a short-term and a long-term context.
Yes, thank you. Now, the members of the task force were determined by the Minister, as I understand the position. And if we can go to the next page, .0132, that and on the following pages, the other members of the task force are identified, and they were essentially government representatives, industry representatives, including a peak body representative, and academics. Is that sort of broadly the coverage?
It wasn't the way in which we looked at the task force. Essentially what we wanted was a mix of experience from research,
Yes.
from vocational training and higher education, government policy and organisational delivery.
Yes.
And the members of the task force were essentially chosen along those lines.
Yes. So it's not your classic pick the leaders of the industry task force. It's quite a different model that was settled upon.
Yeah,
Is that right?
absolutely. I think the first inclination of the minister was a representative model, and we said that. I said that I wasn't prepared to do it if it wasn't a more independent and capable group of thinkers, given the substantive issues that had to be addressed.
It was the relevant expertise that you were looking for
That's
that could
right.
be drawn upon. Now, I need to ask you, because it does jump out at one, looking at the membership, that there's no representative of the workforce. There's no one from a union, for example, that was identified. I know that was not your decision. You've told us the minister chose the members of the task force. But was that a matter? Is that a matter you can shed any light on for the commission as to how that why that happened?
Yeah, it was ultimately, obviously, the selection was a matter for the minister. However, I made sure that through the process of forming this group, that I made contact with the senior representatives of each of the unions to discuss the approach and the framing of the task force, with particular emphasis on how they could be involved in a way that would give them complete freedom to push and contribute to the agenda, including the establishment of dedicated working groups and the engagement of the employee representatives throughout the process.
If we can go to page .0137, please. I think there's some information there that is supportive of what you're telling us. The methodology that was used for the preparation of the report involved the identification of task force subject matter experts, as we can see in the left-hand column of page .0137. That could be brought up, please. Thank you. So we see in the top, in the left-hand column there, task force subject matter experts.
That's right.
And then on the right-hand side, about halfway down the right-hand column, we see a heading, technical advisory group chairs and contributors.
That's right.
Do you see that? And then we've got the first dot point, employee needs and expectations, was chaired by Mr. Rob Bonner of the Australian Nursing and Midwifery Federation. Is that an example of the way in which workforce representatives, trade unions were utilised by the committee?
Yes, that is an example. In addition, wherever we held employee consultations across the country, the various union representatives were involved. And certainly, as we started to form up the actions, they were also involved. The recommendations were also involved in discussions.
Yes. The approach that was followed, the methodology that was utilised by the task force, was a highly consultative one. Is that fair to say?
Yes, it was.
And why was that important?
I think
obvious.
What became very clear at the very outset was this is a highly fragmented industry.
Yes.
With at one end sophisticated companies, but dominated by largely small to medium enterprise. There are very many peak bodies that lay some claim to representing this sector. We often would, say there's more peaks in this industry than there is in a small mountain range. And so we had to find a way of bringing everybody together. At the outset, I could only characterise it that it was like lots of different groups that didn't have a lot of time for each other, hadn't taken the time to listen to each other's opinions and points of view. So, and if you're in many ways locked into a contest between government, industry and the unions without really involving the community or the residents and the consumers themselves. So the intention in having a very wide-ranging engagement was to enable all groups to come together so that while we were exploring their point of view, they were also given the opportunity to start to build a greater understanding across the sector. I think I referred in the report to it being an adolescent industry. Well, I think that is a feature of one where we needed to start to create an industry, if you like.
You guessed my next question, Professor Pelaez, which is that you do refer to as a fragmented industry in adolescence. And I'd like to tease that out a little bit more, if I could, please. What leads you to use that description, and what's the significance of it for the workforce issues that we're examining this week?
I think there were a couple of things that came through, whether it be the experience on the financing authority or through the various other interactions. It became very clear that that with the number of bodies representing the industry, there was often not an alignment of interests, quite often competition for membership. The same, I would say, is true in the employee representative space. And so there are lots of groups, if you like, trying to find a position within the industry. At the same time, I witnessed on very many occasions the way in which either the department or the Minister's office would almost take actions that would keep it fragmented and keep it divided, because it seemed like it was easier to manage in those circumstances. And so very often, you know, I would hear somebody putting forward a proposal, and the response to that would be, well, I'm hearing something different in other places. That would be the end of the discussion. So the adolescence is really represented by, I think, three factors. It's that lack of consolidated position, the fragmented way in which government engages it, and you know the very, very many reports, you know, I think that haven't led to decision is an example of the way in which this industry has not been big enough to resist that kind of oppression. It has been quite an oppressed set of circumstances. And then finally, I think the way in which the industry is structured, we often do in Australia talk about small to medium enterprise. Yes. Now, internationally, a small to medium enterprise is between $20 and $50 million of revenue. In this industry, it's between, we're seeing 1 to 5 million, you know, with employees of, you know, up to 20. So unless we start to talk about it as a micro industry that needs to have policy settings to help it to build over time, then I think we're going to face continued issues. So that's another reason why I call it adolescent, is that it's not an industry that hasn't really found a way of properly representing itself.
There are a number of features of the industry, or the sector, depending how one wants to describe it, that are, if not unique, they're unusual. And perhaps if I could just identify a few of those. I mean, one is it's obviously highly dependent on government funding. Yep. And we'll come back to that because that has significance for remuneration levels and some other areas that you examined in the report. Is that right?
Yes, absolutely.
It is also, in one sense, a highly regulated industry, in others less so. Do you understand what I mean by that? There are, at least on the face of it, is highly regulated because of the accreditation systems and the like. But the evidence we've heard in this commission is that in practice, that's not necessarily always the case. You're nodding. You need to say something for the transcript.
Oh, right. Yeah, look, it is. But I think the way that I would position it is it's heavily government funded.
Yes.
With a funding instrument that is very non-specific in the way in which those funds should be deployed.
Yes.
In many instances, leaving it for industry to determine how to make that investment. And in a context where the government took away at a point in time the case mix approach of high to low care, which has then also left them in a position to try and work out how to deploy those resources when that distinction isn't as clear in the system anymore. And so to say that it's highly regulated but yet unregulated, in many respects there's a high level of regulation but not a lot of clarity over the execution.
Yes.
That's creating that sense of not being regulated.
And not necessarily that much accountability for example, expenditure.
Yes.
Yes.
Just before we lose that page that we've got on the screen, the technical advisory groups, you identified as the first of them there, under employee needs and expectations, chaired by Rob Bonner, who was in the Australian Nursing and Midwifery Federation. I assume that that group would have had a number of others of a technical kind who were members. What is the relationship between that group of the nursing cohort that is dedicated to, or predominantly dedicated to, aged care services, and the general nursing workforce, and also within that context, to what extent are there specific enterprise bargaining arrangements for the aged care sector in relation to nursing that doesn't get swept up by the broader group?
If I understand the question you're asking, it helps to understand a little bit the way the unions are structured themselves.
Yes.
So generally speaking, there'll be a part of the union that's very much involved in the industry structure skills, and there'll be a part of the union that's very much focused on the industrial relations framework and the local level negotiations around the awards or around that those structures. Across all 66 industries in Australia, through my experience in chairing the Industry and Skills Committee, they're all roughly structured in the same way. In this instance, when looking at the ANMF and the other unions involved in this space, the ANMF is tilted more to nursing, and some personal care workers, and in the other unions maybe a predominance of personal care worker and other sort of health areas. In terms of a specific focus on the aged care sector, it tends to sit within the overall brief, because they look at acute and subacute and across the whole range of nursing. Aged care will fall within it, but it's not a separate union in its own right.
Perhaps I could just jump in there, Commissioner. We will have witnesses later this week from the Federation, including Mr Bonnet this afternoon, who may be better placed with respect to Professor Pelaez to expand on those matters.
What I was really curious about was the extent to which there might have been individual people in the technical advisory group of this exercise. But I think we've had probably the answer that we're going to get out of that. Yep.
Thank you. Before we turn to look at the specifics of the report, if I could just ask a couple more general questions, one of which relates to union involvement in the sector. It's actually a matter that's identified in the report itself, isn't it? That is the historical enmity, if that's not too strong a word, between some of the providers and the unions. And the point, as I understand it from the report, is that the unions have a lot to offer to the sector in relation to many of the issues that are of concern in relation to workforce, and it's a matter the task force is keen, as I read the report, for those relationships to be developed in future.
Yes, again, it goes back to that adolescence point, is that the unions have an enormous amount to contribute to the skills agenda and to the, if you like, to industry broadly hearing more clearly what the employees are saying. I wouldn't necessarily say that there was enmity in the system. It was probably, in my experience, the industry really had no contact with the senior members of the union movement, because many of them are small to medium enterprises who are only facing up to the collective bargaining negotiations on a periodic basis. I think through the course of this work, relationships were built at a more senior level, and I genuinely do hope that they go on and continue.
Yes. Because
through the course of that work, I think there was a recognition that many of their needs are very much aligned.
Yes. I take it from that you're referring to the more sort of strategic dimensions the ANMF is a good example, I suppose, of that, without wanting to single one out.
Yeah.
The opportunities that are presented there for the sector to have discussions at those levels. With
to look at, whether it be to look at the total industrial relations framework, the funding mechanisms, the emergence of new job roles, certainly at that level they're best able to have that discussion.
It's important, is it not, to recognise, Professor, that just as the industry doesn't necessarily speak with one voice, neither do the unions. They don't have identical interests. One has to acknowledge that.
Yeah, that's true. I think it has been a concern through the course of the work that quite often because the nursing employee representatives are probably more developed and more vocal and have a clearer agenda, that often it sounds like nurses and then everybody else, and often a perception in the community that in order for the needs of nurses to advance, it's somehow at the cost or the enemy is the personal care worker. In fact, I think what the experience we had is that once we recognise it's an and, not an or, then we do need to do more for nurses and we need to do more for the other employee groups within the industry.
If I can take you to your statement at page .0011, please, and to orient you, it's page 11 in the bottom left-hand corner too, fortunately. You were asked a question: what is the significance of structuring the report as a strategy with recommended strategic actions rather than a report with recommendations? Is that just semantics, or is there an important distinction?
No, it is an important distinction. I think again, I was very clear with the Minister that this could not be just another review. I was very clear that we needed, if this was genuinely an industry strategy, to be able to have decisions taken up by industry and put into action as soon as they were clear, and that this report couldn't be held off by government before its findings were made available for industry to make progress. I think the other point too, and in limiting ourselves to only 14 strategic action recommendations, was to be very clear of the need to make progress and be very clear on the actions that we were looking to take in a very defined time frame.
You say in your statement that the actions are interrelated and interdependent. Can I ask you to expand on that? What do you mean by that?
Well, there were two very important starting points to our work, and that was to define who the consumer was and who the industry is. And if I touch on those and then explain the interrelationships, is firstly we said that the consumer really has to be the individual, their family, their community, their carers, because quite often they have a point of view and they don't always align, but they do need to be heard, and that's not fully represented in the current system. The second was to recognise that in a rapidly ageing population, we needed to think about, and we wanted to be more consumer focused, we need to think about consumers, and we chose looking from 65 through to death. And it was interesting that at the time there wasn't any recognition of death even in the industry's roadmap. At the same time, if you look at those prematurely ageing groups, the homeless, the Indigenous and Torres Strait Islanders, the disabled, you really need to be looking from 50. If you take that journey, then you really have to consider an aged care workforce that starts with financial planning, primary care, home care, residential care, acute, subacute care, functional care. We avoided using the expression allied health because it implied nurses and everybody else, and started to want to give more voice to occupational therapists, physiotherapists, etc., who play a role in frontline ageing. And then, of course, the government systems navigators and the carers. So if you think about the needs of a rapidly ageing population, we need to start thinking about the workforce more broadly, because quite often issues that appear in that earlier journey land at the door of residential care, and then it's an employee who needs to work that through. If you take that point of view, then the interrelated issues are then do go to the mindset of people when they're coming in, what their expectations are. It goes to the way the system interfaces with the other elements of the health system, which is currently quite siloed. It goes to the training needs and job roles that are evolving based on those changing expectations. So a simple example of why it's important to interrelate them is when we did the community and the employee consultations. Yes. Interestingly, both groups independently were referencing that somewhere between 20 and 30% of current employees didn't fit, or they didn't think were the right people for the industry. Now, we took a view in our work that we wouldn't victim bash, because we're talking about people who are underpaid, under-recognised, in jobs that aren't properly graded, trying to do the very best they can. If you only solve one of the 14 issues that we identify as recommendation areas, then you'll end up with the problem just moving into another area. And that's really why we described it as being a high level of interrelationship and dependency that needed to be resolved by making sure each of those areas are addressed.
Now, in the time we have available, I don't think I can ask you about each of the strategic actions. They're obviously all set out in the report. There are a couple that I would like to ask you to focus on. The first of them is Strategic Action 7, which is set out in the report at page 0083. And it's headed Implementing New Attraction and Retention Strategies for the Workforce. And if I may say so, it seems to go to the heart of what the task force was all about, which is tackling attraction and retention as being an essential part of the exercise, or a necessary part of the exercise. There's a recognition on page 0083. If you have a copy, do you have a hard copy of the report in front of you? It's page 54 of the report, if that assists. You see that Strategic Action 7?
Yes.
Yes. And then about halfway down the left-hand column, there's a paragraph that starts, reinforcing a strong and respected industry reputation provides an essential foundation. And then it says, the current reality is that the industry is not viewed as an employer or career of choice. And that's consistent with a great deal of the evidence that we've heard in the Royal Commission. And I couldn't help noticing that one of the witnesses in the video that we showed earlier, were you in the room when we showed that video earlier? Witness who said that needs to be an industry that wants to attract people. And we know the demands. We've all heard the figures, the sort of numbers that are needed to be attracted over the next generation. And so I suppose the question that I have for you is what needs to be done, or perhaps another way of putting it is who's responsible for making it a more attractive industry for young people and other workers to want to work in?
There's two parts answer to that question. Firstly, I think it is the responsibility of all. It's an all of government responsibility and all of community and all of industry. And I'll say all of government because the thing that I found most challenging through the period of doing the report is the extent to which the Department of Ageing is so isolated, even amongst all other government departments. And the extent to which it's very, very difficult to get the government interested in having a COAG-style council on ageing to really make sure that we're having the discussion across state boundaries also, because many of the issues could be addressed with an all-of-government approach. At the same time, you can only get to the really to the attraction and retention if you deal with, I think, 6 things beforehand that really go to it. And they do happen to map to the strategic actions. But the first one is that there has to be a very proactive approach to a social change campaign around ageing in Australia.
That's strategic action one?
Strategic action one.
Yes.
Secondly, we need to really look at job roles and the types of jobs that are available and the career opportunities within the industry. That goes to 3 and 4. Because ultimately, if young people in particular, but also older people, somebody who's 45 still has 15 years of career ahead of them, they need to know that there is a job, what the job's role is, how it contributes to the organisation. And what we did find in our attraction and retention work is that if people understood their job role and how it contributed to the organisation, they were more inclined to score highly in their engagement. The need for a code of practice is raised there also because it's an industry that hasn't defined itself. So it gets caught up in this clinical fight over a system that's come out of basically been born out of a hospital system. Community expectation is that it'll be a living well model, and without a clear statement of what the industry stands for, it keeps being buffeted by that debate. And the one thing that's absolutely clear, that any industry will not attract talent if its purpose isn't clear. If there's a strong sense of purpose, people will want to belong to it and it'll define the behaviours. And so a lot of the work that we did when we started in asking the question why this industry matters is to establish that purpose, because that will attract people. The next one I think is that that people will want to come into an environment where they are given access to lifelong learning, where they can see career paths and the ability to move across. And today the industry is largely defined by the personal care worker, and we'd even argue that the word worker has to be lost to give more respect to the position as training and quality increases. An enrolled nurse and a registered nurse, but there are many other roles that are emerging in this industry that are very exciting, including starting to think about nurses as clinical specialists to enable them to do the job that they've been trained to do and not be part-time administrators, or, as I think Professor Egan mentioned in her evidence around the burden of paperwork. Then I think that the next factor that came in very heavily is the extent to which you've got environments where you have open feedback and continuous improvement. And quite often when we talk about the quality standards, they're a minimum standard, but you need the industry to be constantly looking to beat those standards, to stay in tune with community expectations. That does require a pre-employment screening to make sure you've got the right people to help them find the right careers, but also a much greater focus on development. We suggested 360-degree development planning in our work. So there's a whole series of things that you would need to do to make this an attractive industry. I think the last one that I would say is to make sure, the whole question of workforce planning, I'm sure we'll come to, so I'm hoping we'll come to that. We won't necessarily do that right now. But we were very surprised to see in the employee survey that we did of just over 2,800, the extent to which there is a mismatch between the view of management on how things are proceeding versus the employees. Very large mismatch. And that goes down to understanding the enablement, do people have what they need to do their job, and the engagement issues in the businesses. That does require industry benchmarking, but it fundamentally requires each business to sit down and have that conversation with their own employees to work out what are the issues that are getting in the way. And that is a leadership issue within the industry. So you can see that there are a number of factors that need to be addressed that get to the attraction and retention, given the kinds of quality that we're going to need and the talent we want to retain.
Yep. There's a lot there to unpack, Professor. Can I start with engagement and enablement, two terms that you've used? I think we are very close to where we need to be. It's page .0085. There's a reference in the report to a survey that was conducted as part of the task force's report that surveyed some 2,817 people, asking a range of questions about the employees' perspectives of the work that they were doing. You said there was a mismatch between the views of management, the views of the employees. What was the mismatch?
When we, in the study, when we looked at each of the questions that were asked on the way through, and we looked at management, we looked at direct care, indirect care,
Yes.
And the very important roles that are involved in delivering, living well model of care, whether that be mealtime, guarding, laundry, so forth. Invariably what we found was that the management, the nurse unit leaders, the team leaders were all feeling more enabled and more engaged than the personal care workers, the nurses or the other employees. And you'll note, and from the graph that you're showing there on that page, that already, by comparison to other norms within the healthcare industry or Australian norms, engagement and enablement are already very low. So off a low benchmark, you've got some groups feeling positive and some feeling very negative. And that mismatch suggests strongly that the time is not being taken at a local business level to really speak to the employees, find out what the issues are, engage in continuous employment. And many of the things that I'm sure you've heard, the focus on ACFI, the scheduling issues, very high levels of employee either absenteeism, churn or unfilled vacancies, could create a circumstance where a business might say it doesn't have time to do those things. It's the most important thing they need to be doing.
That of course, can become a self-fulfilling prophecy.
Absolutely.
Can't it? Just perpetuates itself.
Yeah.
Can I just ask a simple question? Do you think the people leading the aged care industry actually understand the importance of this question?
I think, Commissioner, that I think we've got to keep going back and reminding ourselves that many of these are very small companies that have grown over time and haven't necessarily developed those skill sets. And so when we do start to think about the transition of this industry, it's not just about skilling people as they come in or personal care workers and nurses. There is a leadership growth requirement right across the board that needs to reflect the size, the small business all the way through if we're going to get the kind of shift that we need.
So just follow up. Sorry, Commissioner, was that all you?
That's it, thanks.
Yeah, if I could just follow up on Commissioner Briggs's question. One of the themes that runs through a lot of the evidence we've heard here is questions about adequacy of governance and governance arrangements within aged care providers. Do you have a view about that, linked perhaps to your earlier comments about immaturity and
Yes.
so on?
There's a couple of points that I would make on that one. Firstly, I think the role of the boards within this industry needs to be substantially lifted around their understanding and their commitment to doing better than the government-regulated quality standards, which I regard as a minimum. And I often use an example of Sarbanes-Oxley when it came out as a model globally, which was essentially saying that as a chief executive or as a board, you have to self-assess each year to see where you're marginally deficient, meets, beats, and hopefully exceeds. And those companies who take it on just to get to the minimum will always be just focused on their compliance obligation. Those companies that want to be world-class and want to take themselves forward are always saying, well, how do we get to the exceeds on these dimensions? And we'll introduce the areas that take them beyond. And I think boards need to have a greater, and in fact, I think that even the Quality and Safety Commission could play a role in continuous improvement. But boards need to be thinking about that mindset of how do you go beyond, not just meet. Now, the second issue I think with boards is that, again, a symptom of being an adolescent industry is, and frankly, and I'm quite pleased to hear that you're going to spend so much time next year on the funding issues, but in an underfunded model, as I believe this is, then many of the boards are volunteers, and that may not necessarily have the kind of training, the development themselves required to provide the governance to organisations like this, even though they give so much of their time and their commitment and we should be grateful for that, but they certainly could do with some support also.
You mentioned workforce planning, and I've taken my cue from your request that we address that. So if I could ask you to go to Strategic Action 6, which is on page .0077, page 48 of the report, hard copy in front of you. Strategic Action 6 is establishing a new industry approach to workforce planning, including skills mix modelling. What's the central concern here, Professor?
I think it goes to, and I think it was also reflected in Professor Egan's report, is the absence of a capability around workforce planning in this industry. It's, again, if I draw on my experience in the aged care, in the Industry and Skills Committee, there aren't too many industries in Australia that are very strong on workforce planning. And in fact, it's a program that's currently being rolled out across all 66 industries with respect to training, to start to have them think more about it and the way in which jobs are changing and career paths are developing. I think the critical nature of this industry, though, is that, again, having come out of a clinical and hospital-based system, it's got a scheduling mindset, not a workforce planning and a skill set mindset. And again, take this comment in the context of the very many small to medium enterprises and the more sophisticated companies you'd expect to be addressing this. So we looked in depth at about 30 businesses across home care, residential care, and rural and remote to really understand the workforce organisational structure, job role, job accountability, all those types of things. And it became clear there wasn't a very sophisticated approach to workforce planning. So in fact, what we did is we looked at the ANMF model for workforce planning. And it's a very good model in that it identifies the consumer profiles. I think in some ways, Professor Egan's work on case mix is a similar idea. Trying to understand what the kind of theoretical case mix is. Although I'll comment on why I think that the professor's work is a step up on that. Then they looked at what the clinical interventions were in the AM and the PM. They aggregated those. That then gives you the ratios. So we simply took that model and we said, what's different in this industry? So what's different is that in this industry, in looking at the case mix, we suggested that we need to think about holistic care planning. So instead of just clinical needs, it's your clinical needs, your functional health needs, your cognitive health needs, your cultural and linguistic needs, and your living well aspirations as the 5 elements of a care plan. And that rather than just looking at the AM and the PM, you needed to look at the AM, the PM, the night time, and the weekend. Aggregate those interventions, and that then tells you the skills mix. Now, certainly I think that there's often this question that's raised around ratios. Well, every business runs on ratios. It's just a question of when you apply them. Yes. And I think what we identified here, that to reflect the differences in the different business models, case mix was absolutely required as a model. But importantly, the case mix needs to take into consideration those 5 factors of a holistic care plan, and then that drives through on the skills mix. Now, you can't just expect that this is a way of planning that businesses can just adopt, because it is a skill set in and of itself that needs to be brought into industry. If I could just go one moment longer, the same issue applies in the home care industry. Because in home care, again, it's coming out of a scheduling mindset, having somebody turn up for this amount of time, whereas when you look at businesses that are managing large field forces that are out and just doing their work in the field, there's a very different set of skills that then would give you a stronger cultural consistency, career pathing for those same roles, etc. So I think what we identified in Strategic Action 6 is to treat this as a skill deficiency of itself that we need to start to evolve within industry.
Commissioner, about to go on to a new topic that might be an appropriate time.
Well, we're wondering whether, if we sat on until 1 o'clock, whether you might.
I will conclude, Professor Police.
I think that would be desirable.
I'd be
then, I
grateful
think,
for
yeah.
that. Thank you. Yes. Sorry, Professor. I wanted to move on to a broader question about the role of the government. We've talked a lot about the responsibility of the sector, and you've already identified one of the difficulties with that, even conceptually, is the sector doesn't speak with one voice, and necessarily CEOs come and CEOs go and boards change and so on. So it raises a question for the Commission as to what's the responsibility of the constant in all of this, and that's the government, of course. I note in your statement, this is at page 12, if we could go to this, you're asked a question about the progress of, in relation to each of the strategic actions. And, of course, a number of the strategic actions are directed at the government, are they not? Many are directed at industry, but there's 4 or 5, depending how you unpack it, I suppose, which are directed straight at government to implement. Is that the case?
That's correct.
And you've identified the 5 which fall into that category in the right-hand column of your statement there. And we know that you say you're yet to hear the government's response in relation to those 5. And perhaps we could just list them. 1 is the creation of the social change campaign you discussed earlier. 9 is strengthening the interface between aged care and primary and acute care. 10 is improved training and recruitment practices for the Australian Government's own aged care workforce. 12 is the establishment of an aged care centre for growth and translational research. And finally, 13 is current and future funding considerations, including staff remuneration. You say you're yet to hear the government's response to those. Do you mean by that there's been no formal announcement about the government's implementation of those strategic actions?
Yes, in fact, there's been no detailed response at all to each of those recommendations, but for a pre-election commitment to fund the Aged Care Centre for Growth and Translation Research,
number 12.
which I haven't seen any progress on. But with all others, I wrote to the Minister asking for a point-by-point response to those, and did not receive a response. I think they're important because Strategic Action 1 is a co-commitment, if you like, between industry and government. It's one that needs to be done together. But essentially what we were focusing on is, in the philosophy of the task force was, let's see how far industry can go on its own,
yes,
and then what's left is the work of government. So that we made sure that not everything was, oh, well, if the government doesn't do it, we can't do it. And industry have been stepping up in this time frame. They have responded in the main.
Yes.
But on these areas, we haven't had a response at all from government.
And Professor, when you say that you haven't had a response to your letter, do you mean by that there's not even been an acknowledgement of receipt of your letter?
So I got an email response that was all of the past programs of government, and I went back and said, look, that isn't sufficient. I'm asking for a step-by-step response. I didn't get a response to that email.
At all?
At all.
It's got to be profoundly disappointing, I suggest, Professor Police.
It is, although I think I took the view at the time that I would then just really focus on working with industry to get the progress there. I think that I made the observation at the very beginning of the evidence today that I felt that in many ways the industry was undergoing a level of oppression, maybe not the right word, but I do believe that that this is not a department that is resourced well enough, that has sufficient experience or weight within the current government department that it sits. Quite often the secretary, the deputy secretaries have other portfolios, so not the focus. I was very surprised through the course of the work, the extent to which PM&C, the Prime Minister and Cabinet, were sitting on top of the Minister with respect to these issues. And I was very surprised in many instances about how important it was for me to speak to the Minister to ensure that he got a full briefing. and that whenever I spoke to the secretary of the department, it was always in such a way that there were a number of people around. It was almost impossible to give as frank a point of view as you would. So my sense is that the way that government has positioned itself over the last few years is that, to the extent that this can be an industry issue and they can leave industry to deal with union, and then use the fragmentation as a reason to say, well, without one voice we don't know what you're asking, has been a reasonably successful approach, and if not a strategic approach, then a real shame, because the answers to many of these questions have been on the table for quite some time.
Strategic Action 14 is the one that proposes a mechanism for implementation of the other 13. It proposes an industry-led body that is charged with giving effect to the recommendations that are focused on the aged care industry. Mm-hmm. And we'll be hearing shortly, in fact after lunch, from Kevin McCoy, who's the acting chair of that council. What was the thinking behind having an industry body to pick up the strategic actions and run with them? Why was that important?
Because I guess ultimately the only way that a strategy is going to get executed, if it's owned, as if they wrote it themselves, by the leaders of the industry. If you continue to push down a regulatory path, then it'll always be a question of, what's the line? It's it creates a notion of of trying to just make sure that you hit the minimums and that you don't fall under. The line becomes focused, if you like, target fixation kind of thinking. Whereas if you can get the industry to own and take responsibility for a living well model of care that is moving with consumer expectation, then there's be less dependency upon government over time, and you'll start to see that maturity and strengthening. The thinking around having a workforce council that was the responsibility of the CEOs of the industry, not delegated to any other level, that worked in collaboration with community representatives and with union representatives to steward this, meant that we could also create a system whereby there would be the interdependencies would be dealt with. So part of the construct of the Workforce Council was to ensure that the Industry Reference Committee that's responsible for training is hooked into it, the Remote Accord was hooked into it, if the Research Translation and Growth Centre, which hopefully will bring all these sort of small pots of money and give a much greater dedication to research in this sector, it would mean that all of the workforce issues would come together. The other principle that I did discuss at many occasions with Minister Wyatt, who I would say was a very proactive supporter of the work and kept pushing me to take the licence to open up the issues, was that if you have the Quality and Safety Commission, if you've got a clear industry code of conduct, if you have the Centre for Research Translation that takes us forward, and you've got a very clear workforce strategy, then you start to have the ecosystem that you need. Then the only thing that's missing, frankly, and hopefully it's the work that's informed by Professor Egan, is a funding system that recognises case mix, and then many of the issues are addressed. So the Workforce Council, therefore, was really the start of creating that pillar in the ecosystem, so that there was a group that had responsibility that you could look to, that had a single voice, that could then deal with the government and the industry when it came to ensuring that the issues of workforce were addressed.
Two last matters, if I can deal with them briefly. The first is the strategic action number 12, the Centre for Growth and Translational Research, which you've referred to a couple of times. It's dealt with at page .0113 of the report, page 84 of the one you've got in front of you, Professor. Why was that considered to be important, and what's it intended to do?
So I guess if all of the other recommendations are focused on resolving issues of today, the backlog of issues to ensure that we set this industry right, then strategic action 12 is all about ensuring we do the research that we need going forward, not just on new models of care, but on the translation of those into practice. It's a great shame and that we often refer to great examples around the world, but if you go and have a look at all those great examples of the world, they're also very subscale pilots that haven't been scaled up.
Yes.
And if you consider that we're going to have 25% of our population over 65, highest net contributor to the economy, because we are talking about baby boomers who do spend their money, then you're talking about an economic opportunity for this country, not just a social need today. That needs to be supported by good research, and not the little doled out $1 million here, $5 million there of research that doesn't go anywhere. Substantial research. Now you've got a department that is sitting within the health department that has a $1 billion, or I don't know exactly the amount of money, but
money though.
Medical Research Translation Fund,
Yes.
that isn't focused on probably one of the greatest areas of need. Not at all to in any way undermine the validity of other medical research, but this is a very important area of social research. If we want to get right, it does require investment, and it does require an ability to translate to practice and scale up. And so 12 is really an attempt to say, let's take the learning out of the other growth centres that exist in other industries that the government is supporting,
Yes.
and put it in place and have it then work to ensure that we get the right level and quality of research.
And of course, we have in Australia world-class aged care research facilities like NARI, for example,
Absolutely.
don't we? And yet, am I correct in understanding no real government response to Strategic Action 12, to your knowledge?
Other than a pre-election commitment, which I think was driven by the electoral timing, there's been no further detailed, and we had submitted a detailed recommendation as part of this report. We'd since submitted a recommendation that was slightly less funding requirement to try and get it over the line, but no response. And that's been to the Minister, and it's also been to the Secretary of the Department of Health.
Final matter concerns time frame. There's a suggestion in the report of a 1 to 3 year time frame for completion of. I'm not overstating the position, but that's identified as a realistic time frame. Is it realistic, do you think?
So it needs a little bit more qualification. So in recommendation 14, I think there's 6 work streams. One of them so all of the work streams are feasible within that time frame, but one of those work streams is the leadership development incubator, which is about really looking at how you transition the leadership from the current standard to a different standard. That does require a substantial level of funding support, or I don't know if you'd regard it as substantial, but we did suggest to the Minister that would be around a $7 million investment. To put that in the context of our report finding, funding gap of around $3.5 billion when it came to workforce issues, then investing in developing the leadership in a very clear program was required. The 1 to 3 is around setting things right, and then I think you'll see that we'll also refer to 5 to 7, which is really premised off the work coming out of that recommendation 12. If we want to transition the workforce entirely to new sets of standards, so say for example, we wanted to, when the new Cert 3 is developed, we want to bring all employees up into that standard, that probably is a 3 to 5 year exercise.
Thank you. They're my questions for Professor Pallairs.
Thank you. Professor, I should not limit my thanks to you just from the point of view of the Commission. We've learned a great deal from your work. But I think I might extend the thanks on behalf of the entire Australian community for the work that you've done in the past. Having heard you today and seen the details of your report by what you've had to say, I think we've been very greatly indebted to the work that you've done. It's an amazing amount of work. Council referred to the response or non-response as disappointing. I think probably discouraging might have been an even more apt word. I hope that's only a temporary position of the government and that they might think about responding more appropriately. But thank you very much indeed. It's been very helpful.
Commissioner, before Professor Beliers is formally excused, I understand from a learned friend representing the Commonwealth that she would like to get some instructions over lunch about certain aspects of his evidence. I'm not quite sure where that will go, but obviously we'll have some discussions between ourselves about that, and it may be that some further brief evidence is necessary from Professor
All
Beliers
right, well,
after lunch.
subject to that, I think he can be excused subject to that so that he doesn't have to come back if it's not necessary.
Yes, we'll deal with that ourselves. Thank you, sir.
Otherwise, we'll adjourn until 2 o'clock.
All stand. Royal Commission is now adjourned.
Mr. Rosen.
I was called Kevin McCoy. The issue with Mr. Pillay has resolved itself.
Thank you.
He's been excused in accordance with the conditional direction.
Repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Yes, Mr. Rosen.
Commissioner, I neglected to mention that Mr. Heath is here, wanted to announce an appearance for Mr. McCoy. Perhaps that should be done
Yes,
now.
yes.
Apologies.
Please, I appear on behalf of Mr. McCoy.
Yes, Mr. Heath.
Thank you. Sorry about that, Mr. McCoy. Can you state your full name, please, for the purposes of the transcript?
Kevin David McCoy.
And Mr. McCoy, you have made a witness statement for the purposes of the Royal Commission, WIT.0451.0001.001. First page of that should be on the screen in front of you, I hope.
Yes.
And have you had a chance to read through your statement before coming along this afternoon?
Yes.
Is there anything in it you wish to change?
No.
Are its contents true and correct?
Yes.
I tender the witness statement of Mr. McCoy dated 27th of September 2019, Commissioner.
Yes, the statement of Mr. McCoy dated 27th September 2019 will be Exhibit 11-4.
Commission pleases. Mr. McCoy, you are the Chief Executive Officer of the Independent and Assisted Living Platform of Australian Unity.
Yes.
Excuse my ignorance, but what is the Independent and Assisted Living Platform?
So I represent about 65,000 customers across aged care and disability.
And the aged care business of Australian Unity, is it residential care, home care, or a mixture of the two?
It's a mixture of the two.
And are you able to indicate, at least in general terms, the proportion of each?
In terms of residential aged care, we operate 7 aged care facilities with about 1,200 staff. In terms of home care, in terms of home care, we would do about 20,000 home visits a day and staff of around 4,000.
Thank you. You were previously the Group Chief Financial Officer for Australian Unity,
Yes,
and by way of qualifications, you have a Bachelor of Commerce in Accounting, and you're a Chartered Accountant.
yes.
Thank you. Your evidence today concerns the role you play as the Acting Chair of the Aged Care Workforce Industry Council.
Yes.
That's the case, is it not? And that's why we've asked you to come along today. And by way of explanation, the council is the body that has been established arising out of the what's often called the Pillay Task Force report.
Yes.
So the witness prior to you, I'm not sure if you were in the room when Professor Pillay was giving evidence.
No, I wasn't.
Okay. He gave evidence that Strategic Action 14, that is the final action identified in the task force report, was a recommendation in effect to establish the council that you are now the interim chair of, or
Yes.
the acting chair, I should say. I might just clarify that title at the outset, if I could. You were originally appointed to that council as its deputy chair,
Yes,
and that was earlier this year,
that's correct.
2019. And the interim chair was a gentleman called Ian Hardy.
Yes,
Mr. Hardy, unfortunately, is unwell and announced at the September meeting of the council that he was standing down. Is that the case?
that's correct.
And as the deputy chair, you became the acting chair.
Yes.
There is a search for a full-time independent chair at the moment, but for the time being, it remains you.
That's correct.
All right. I'll ask you a little bit more about that search in a moment, but that's the state of play. If I could start by just asking you a little bit about Strategic Action 14 by reference to the Polaris Task Force report, and I'd ask that that be brought up on the screen, please, at page .0130 of the version we were looking at earlier. Sorry, that's the other version. It's the one that starts ACW. My apologies. Just whilst that's coming up, I don't know if you have a copy of the Polaris report in front of you. You do. Terrific. If I can ask you to look, please, at page 101, and then that is the page. Thank you to the operator. So this was the recommendation. If the first paragraph could please be highlighted, we'll see that the Polaris report recommended the task force recommended the establishment of an Aged Services Industry Council to provide the necessary strategic leadership to accelerate the programmatic implementation of the workforce strategy. And it went on, and in the second column, there's a bit that I want to ask you about. It makes reference to, if the second column could be highlighted, it says, to facilitate the implementation of the remaining strategic actions, the Aged Services Industry Council would initiate the following. 6 cross-industry committees will be established to address each of the strategic actions in a coordinated and integrated manner, noting the dependencies between certain actions. That's a process that's still in progress, as I understand it.
That's correct.
Yep. So far, the council has taken a number of preparatory steps. Is that
Yes.
fair to describe them as? And perhaps if I can take you through those by reference to your witness statement. The first thing that has been done is the council has been put on a secure legal footing.
Yes.
It's actually a company limited by guarantee. That's the legal structure that's
Yes.
been settled upon. And presumably that's to enable the body to be able to engage staff, for example, and otherwise incur expenses.
Yeah, exactly.
Yeah. And the various members of the council are directors of that company.
Yes, they're directors.
Yes.
Members are different in the structure.
Sorry, I might get you to
yeah.
expand on that if you could.
Legally,
Yeah.
there's 5 members. There's directors within the structure of the company limited by guarantee, but there's also members.
I see. So the director is a subset of the members. Is that
Yes.
Is that right?
Yeah.
Okay. And you're one of the directors?
Yes.
Okay. Might just perhaps bring up the constitution of the company at this point. It's in tab 43 of the general tender bundle. And if we could go to page .0010, clause 2.1. So we see that the formal name is the Aged Care Workforce Industry Council Limited, and the objects of what is referred to as the company in the Constitution are to improve aged care in Australia by improving the workforce to ensure that, firstly, the workforce provides aged care services that can meet the care needs of older Australians now and into the future, and secondly, older Australians have equitable access to aged care and the dignity to age well, irrespective of setting. So they're the principal objects of the
Yes.
of the company that is the legal manifestation of this council. Is that right?
Yes.
Okay. There's been an appointment made of a secretariat for the council.
That's
Is that
correct.
right? And can you explain to the Commission, please, what the role, as you see it, is of the secretariat?
The Secretariat's role would be to make sure we operate within the bounds of the Constitution and we comply with all the legal requirements we would need to in operating an organisation such as the one we do.
If I could draw your attention to paragraph 27 of your statement, Exhibit 11-4, it's on page 5 of the statement.
Yes?
You note firstly there that Miles Morgan has been appointed as the secretariat function. That's not an individual, is it? That's a company?
Yes.
And they're a consulting firm, are they?
Yeah, my understanding is they're a policy-type consulting firm.
Right. I think I'm right, aren't I? They were also involved in the task force report, at least in providing advice to the task force.
That's correct.
And is that continuity of benefit to the council, do you think?
Yes.
Okay. Because there are no members of the task force on the council, are there? It's an entirely different membership
Yes.
group. And so therefore having that continuity via Miles Morgan, I take it, is of assistance.
Yes.
Ask you about the membership of the council, which you address at paragraph 16 of your statement on page 3. Firstly, who determined the membership of the council, as far as you're aware?
I wasn't involved in the determining of it.
Okay, so I think you deal with this at paragraph 14 of your statement. Was this a process overseen by Miles Morgan?
Yes.
Okay. And as you say at 14, the peak bodies, that is the industry peak bodies, were approached to nominate suitable candidates. 10 industry members of the council were selected based on their capacity and capability, and recognising this role will require a significant commitment of time and resources for a period of no less than 3 years, yeah?
Yeah.
And then we see the current members of the council are set out in paragraph 16, and there's a number of CEOs of providers. You'll need to say something so the transcript picks it up. Ms Hills, for example, from Benetas, is a witness that is going to be giving evidence for us later this week. The people on the council that are not CEOs of providers, if I'm right, are Melissa Code, firstly, from United Voice.
Yes.
You may not know the answer to this, Mr McCoy, but why was that particular union chosen to have a representative on the council?
I don't know the answer.
Don't know. Okay. Do you know from your dealings with Ms Code whether she liaises in any formal way with other unions in her role on the council?
Not directly, no.
Sorry, you don't directly know, or she doesn't directly?
I don't know if she has a formal arrangement in place with them for that.
From her input at council meetings,
My
is it apparent she has some
Yes.
liaison? Yeah,
Yes.
and that's pretty important, I would imagine.
Crucial.
Yes, okay. Other than her, the other non-CEOs are Mr McCallum, who represents National Seniors Australia. It's a consumer organisation.
Yes.
And what, from your perspective, if any, is the benefit of having a representative of that organisation at the council?
In the work we've got to do, keeping consumers front and centre of that work is really important. So having a voice of the consumer on the council always, I think, will be extremely beneficial.
As I read the Polaires report, it was envisaged that this process of implementation of the 14 strategic actions would essentially be driven by the aged care sector itself.
Yes.
Would you agree with that?
Yes.
And the report was quite prescriptive that it was to be the CEOs of various organisations that were to be involved. The CEOs that are on it are mainly of large provider organisations. Is that a fair observation?
Broadly, there is Glenview, CEO of Glenview, which is a small organisation in Tasmania.
Small, or it's certainly smaller than the bigger ones. What do you know?
A lot smaller.
A lot smaller.
Yeah.
Okay. Do you think that from the workings of the council that you've observed that's an adequate representation of the small to medium parts of the sector?
I would, where we are at the moment.
Yes.
There's many ways you could slice the industry by affiliation, by faith, by size. So, but I think from where we are right now, I think it's a good representation.
You've got what you would consider to be an appropriate representation of the for-profit and the not-for-profit sectors.
Yes.
And if I could just ask you some general questions about the council. You've now been to what is 5 meetings, I think there have been, of the council to date?
5, yes.
5. Most recently, last week, I think, was the most recent meeting.
Yes, Thursday.
Can you indicate to the Commission your observations, firstly, of the level of engagement of the council members with the tasks that they have?
Yeah, the members are highly engaged with the task and very committed to the implementation of the recommendations.
That engagement and commitment manifests itself practically in some certain respects, doesn't it? The funding to date, both in kind and actual, has been from a number of the organisations that the CEOs represent.
Yes.
Including Australian Unity.
Yes, that's correct.
I want to ask you a bit about that, particularly the extent to which that's a sustainable formula for the operation of the council. As I understand the position, the council is to operate, is envisaged to operate for a number of years, implementing the strategic actions. Is that right?
Yes.
And from your perspective, as the current chair, is the existing arrangement with funding, where the bulk of the funding seems to be coming with the blessing, essentially, of organisations who have the CEOs on the council, is that sustainable?
I don't believe so at this point, where we are at this stage of the implementation.
Right. What is the range of funding sources that's available beyond what you're getting at the moment? Government is one obvious source.
Government is one.
Yep.
The industry itself.
There could be a levy, for example, imposed on the industry in some way. Is that right?
There could be.
Yep.
There are organisations who are prepared to, put in funds just at the start to get momentum, and then there's other organisations that may provide sponsorship from time to time. So you're right. There are other funding options.
And are they being actively considered by the council? The various options?
They've been discussed, and we're exploring them.
The work of the council, if we could just take one example, there's a suggestion in the minutes, which I'll take you to in a moment, of the meetings of industry surveys being conducted. There's necessarily quite an expensive exercise, is it not?
Yes.
And not to put too fine a point on it, for the council to do the work that it's charged with doing to implement the strategic actions, it needs resources to do that work.
Yes.
Is it part of the thinking to have some form of, to have staff, for example, doing the work? Is that part of the thinking?
Yes.
And what have you got in mind?
Well, across the 60 recommendations, which are the breakdown of those 14 strategic actions,
Yes.
there is a lot of work involved in that.
Yes.
I would imagine we would need some sort of operational function with a CEO, so to speak, and some program and project management capability. It ties back to your opening point, I think, on the mobilising in strategic action 14, mobilising across the 5 areas.
Yes. And that necessarily, as I think you already agree with me, requires some funding.
Yes.
We can see from both your statement and the minutes that there's a monthly meeting plan that has been set in place for the council.
Yes.
I think currently that runs through to the end of next year,
Yes.
which just coincides with our reporting date, as it turns out. I think liaison between the council, at least, sorry, I withdraw that. The council is obviously following the proceedings in the Royal Commission.
Yes.
And similarly, I can indicate to you the Commission is obviously interested in the work of the council.
That's great.
The description you gave before of the membership being motivated and engaged, presumably there's a challenge turning that into action, as with any organisation.
Yes.
Is there anything in your background that that equips you personally for the chairmanship role that you currently have, other than your involvement in the sector, obviously?
Yes, so I have, by way of background, I'm also a qualified project manager. I have significant experience in transformation programs, integrations and acquisitions and significant change programs.
What are the particular challenges here you think that are front and centre in your mind in carrying out this work?
The biggest challenge initially in any program is to get momentum and to get the body tasked with doing it, to get them into some sort of rhythm and cadence. That's what you need to achieve initially.
And presumably that's a function, at least in part, of leadership, of whatever the body is.
Yes.
And also relies on the commitment and enthusiasm of those involved, as you've told us.
Absolutely.
I want to ask you a little bit about the government and how you see the federal government's role working in relation to the council. If I could start by just reading to you, without necessarily having it brought up on the screen, part of Strategic Action 14 in the Polaires report. The report's authors wrote, the council will take, that is your council, will take ownership of the implementation of the recommendations. It will shape and oversee the delivery of the outcomes, working with industry and government throughout the process. And the word throughout is highlighted in that. I take it you recognise the importance of engagement with the government in the work that you're doing?
Yes, very important.
Why is that? What is it about engagement with the government that's so important to achieving, implementing the strategic actions?
They're one of the significant stakeholders in the aged care industry. So, they set the standards and provide most of the funding at the moment. So it's really important that they're a big part of the work we do. And, their input, to my earlier point of momentum, their input and their backing will give us, tremendous momentum.
Is there also a practical dimension to this? The CEOs will come and go, and the one, and even the industry changes significantly over time, but the federal government's obviously going to remain a constant in relation to workforce issues. You agree with that?
Yes, yes.
In your statement, there are a few references to the limited success that you've had in engaging with the government. Is that a fair description of the track record?
In my 4 weeks or so of being the chair, yes.
But even before that, you were at meetings where your predecessor was reporting on his dealings with
Yes.
government, and I'll take you to what the minutes record about that in a moment. But firstly, if I could just note a couple of things in your statement and see if we can tease them out. Firstly, paragraph 27 on page 5, which I asked you about a moment ago. This is the reference to Miles Morgan and the role of Secretariat, and you suggest there that appointment might assist to ensure the government has visibility of the council's operations, firstly. I'll just read a few of these to you and then I'll ask you to make a comment if I could, please, Mr McCoy. At paragraph 28, you say the council itself does not have explicitly defined reporting lines to the Minister for Aged Care, nor the Department of Health or the industry more broadly. And then you go on and make reference to the stakeholder engagement plan, which you've kindly provided to the Commission. And 29, you say the council is also looking to engage directly with the Minister for Senior Australians and Aged Care so as to ensure the Minister has visibility of the implementation of the strategy. To support this, the council is seeking to establish a memorandum of understanding with the Department of Health to ensure strategic actions that are to be led by government are actioned in a collaborative way with the council supporting the Department of Health. Do you see that there in paragraph 29?
Yes.
I want to ask you a little bit about that memorandum of understanding. Firstly, was that the council's idea or the government's?
The council's idea.
Okay. And what is the thinking behind formalising the relationship in an MOU in that way?
I think a memorandum of understanding is a very good tool to smoke out exactly what both parties want out of something. So it just gives you clarity on roles and responsibilities and accountability.
And are you able to indicate from the council's perspective where you're up to with the MOU? What's the status of those discussions?
We haven't had a discussion yet on the MOU. I haven't personally.
Okay.
My understanding is Miles Morgan has had one meeting with the department where they've raised the subject of an MOU.
A draft MOU has been provided to the Commission. I take it you haven't seen that?
No.
Okay. Paragraph 47 of your statement on page 7, you say the council has sought engagement with the Department of Health since its formal establishment in May.
Yes.
It's now the middle of October. There's a Royal Commission into Aged Care that's been running in the interim. Firstly, have you had a phone conversation with any senior officers of the Department of Health about the work of the council?
Yes.
And who have you spoken to, Mr McCoy?
Just bear with me, I'll look at my notes.
Sure. I might be able to help you. Is it Ms Macaulay or Mr
Yes.
Wan? Ms Macaulay.
Yes. I was looking for the title.
Yep. Okay.
So I've spoken, Kate Macaulay's dialed into 2 council meetings, so meeting 4 and 5.
Yes.
And then I've had a 10 or 15 minute conversation with Kate,
Yes.
which was a very convivial conversation.
Yes.
No warning signs for me.
Okay. And you refer to the dial-in at paragraph 48, and I take it that she also dialed into the more recent meeting that's been held since you made the statement. Is that
Yes.
right? Okay. It might just be me, but dialling into a meeting from Canberra seems to show less of a commitment than actually turning up, being physically present at the meeting, or is that a distinction that you don't think's so important?
I mean, it's hard to comment on that. Hopefully in time we can get to a point where we can have more face-to-face interaction.
Yes. I take it your schedule of meetings has been provided to the Department of Health?
My understanding is it has.
I want to ask you some questions about the minutes of the council meetings, and the first of those that I want to ask you about is at tab 136 in the general tender bundle. And just to give you a bit of context here, Mr McCoy, this is a meeting on the 20th of June 2019, so would that be the second meeting of the council? Does that sound right?
Yes.
One where Mr Polaires gave a presentation, and I won't ask you about that presentation, but I want to ask you about something on the second page of the minutes, which is .0039. Right down towards the bottom of that page, the second last black dot point says consideration to be given to having someone from the Quality and Safety Commission to be an ex officio member of the council. Do you recall that discussion?
I wasn't at that meeting.
Ah, okay. I see you're an apology. Do you have any knowledge of that from subsequent discussions?
We've had a few discussions on various stakeholders
Yes.
across the industry, and we're exploring ways of how we engage everyone, either through participation in the council, structural changes to the constitution, or ex officio, or reporting.
Okay. So it's possible that that might still occur?
It's possible.
You're not aware of any further developments by way of an approach to the Commission?
I'm not.
All right, thank you. If I can take you to, in the same minutes, 2 pages further on, .0041, there's a heading agreeing implementation priorities. And you'll see there, and I'm conscious that you weren't, of course, at this meeting, but you'll see there the reference to the chair. That would have been Mr Hardy at that time. Is that right?
Yeah.
Had a telephone conversation with Charles Wan, the First Assistant Secretary in the Department of Health in charge of aged care reform. Charles informed the chair that 1.2 million was to be allocated to the council to further its aims in the financial year 2019-20. A further 600,000 was going to be made available for training. This funding may be available to the council, subject to its work program. No funding has been committed by the department to the council beyond 2019-20. Now, just pausing there in the reading, as I read your statement, the arrangements for funding other than for Miles Morgan as the Secretariat service are really up in the air at the moment, are they not?
That's correct.
So despite that reference back in June, Commonwealth funding has not been forthcoming to the council.
No.
And I take it that's not for lack of trying on the part of the council?
No.
Is it a disappointment to you that that matter has not been able to be resolved in the time since May when the council was established?
I mean, there's a matter of care and the recommendations. It's a lot of work, and it takes some time to get a piece of work like this mobilised and agreement with all stakeholders and buy-in. So, look, I understand your point, but in the scheme of what we've got to achieve and the complexity of the industry, I think we've just got to work harder to embrace all the stakeholders.
It's relatively early days, I think.
Yes.
Is it fair to say?
It's relatively early days, but there's a three-year plan, as I understand it.
Yes.
Working with, as we heard from Mr Pollier's before lunch, a very fragmented sector. In order to get all those action items with all those sub-elements adding up to 60 done, it suggests there's a need for some pretty strong and concerted action, as you say, Mr McCoy. Is this possible without more government support than is evident to date?
It won't be possible without strong government support.
Who established you? Who gave the instructions to the lawyers to create the Constitution?
I wasn't involved in creating the Constitution. My understanding is Miles Morgan were instructed.
and it was created. Was it, to what extent is it your understanding that government had been involved in the giving of the instructions for the creation of the Constitution?
I don't know what involvement the government's had in the...
All right, let me rephrase it. Do you know whether it had any involvement?
I don't know the answer to that.
And the selection of the 5 members, did the government have any involvement in the selection of the 5 members?
I don't know the answer.
You don't know the answer. Do you have any basis for assuming that the government did have any involvement in the selection of the 5 members?
No.
Is it a fair assumption to assume that the Constitution was essentially created by the 5 initial members because they thought it would be a good idea to link into Action Plan 14?
I think my understanding is it was a way they had to mobilise quickly, form a corporate body.
So is the answer to my question that you think that's a fair inference to draw?
I'm not really clear on the inference.
That the 5 initial members were the ones who thought it would be a good idea to create this body in order to capture the advantages or to come within the terms of Action Plan 14.
Sorry, Commissioner, I may have misled you on the 5 members. The Constitution allows for 5 members. There aren't actually appointed 5 members.
I see. All right, well, forget the number 5. If I substitute the number 5 with initial members, which I think is the term identified in the Constitution, would what I said be right? Is that a yes?
I don't think that's correct.
So the initial members, my proposition to you is it a fair assumption to make that those people who were the initial members were the ones who thought it would be a good idea to create this body for the purposes of furthering Action Plan 14?
The appointment of the directors was a...
No, I'm not asking about the directors. I'm asking you quite correctly corrected Mr. Rosen earlier on in drawing a distinction between the members and the directors. There is a distinction, isn't there?
Yes.
Yes. And the members are the people identified as the initial members, correct?
Yes.
And they are limited in number.
The 3, yes.
They are now only 3.
There's 3
Yes.
members.
Whereas the directors may be as many as 11.
Yes.
And they are intended to be skills-based.
Yes.
Whereas the members are different. What I'm asking you about is whether it's a fair inference to draw that the initial members were the ones who thought it would be a good idea to create this body to come within the objectives of Action Plan 14.
I don't know the answer.
You don't know the answer. Okay.
Commissioner, can I approach it this way? Because I think I may have introduced some confusion into this and I apologise for that. If we go back to paragraph 12 of your statement, Mr McCoy, on page 2, before there was any suggestion of creating a corporate entity, there was a council established, was there not, by the Commonwealth via Miles Morgan. People were identified to be members of an aged care industry workforce council. Is that right?
So before the 5th of February, 12th of February, was there a council?
Yes.
No.
No, not before the 12th of February. The entity was incorporated in May, was it not? Registered on the 17th of May.
Yes,
Before that, there had been a workshop in February.
that's correct.
The workshop was attended by council members who at that time were operating on a council that had no corporate status but had been established by the Commonwealth.
I don't believe so. The workshop was attended by approximately 40 leaders from across the industry,
Right.
and the point of the workshop was to talk about what would be the sort of makeup of the council.
I see.
So, for example, would it be just providers or not? Would it have employee nominee representation or not?
Okay. But I'm just trying to understand the process and the link to the Commonwealth. You understand that's what I'm trying to explore here.
I understand, but I was not involved in the establishment of it.
But you do say at paragraph 12 that you understand the Commonwealth Department of Health engaged Miles Morgan on the 5th of December 2018 to support the establishment of the council.
Yes,
And then the process of the workshop and everything else that you've described
that's correct.
flowed. But it was always the intention, was it not, that the body that emerged from this, the council, whether it had corporate status or not, would be the body envisaged by Strategic Action 14.
That's correct.
That's what this was all about.
Yes.
All right, thank you.
But my confusion, which stemmed from paragraph 12, was that the implication from paragraph 12 was that what has emerged had been caused by the Commonwealth, whereas in fact the answers that I'm getting seem to indicate that the Commonwealth is not the cause of the body that's been created. The body that's been created is essentially three industry participants thinking it would be a good idea to create it.
Are you able to clarify?
Commissioner, I don't believe that's the... I think the Commonwealth engaged Miles Morgan to create a council. Miles Morgan have come up with what they think the entity structure should be, which is a company limited by guarantee. In parallel, they've reached out to the industry for suggested members of the council, and because the company limited by guarantee needs members, they've then gone and sought membership for the Workforce Council. That's my understanding of how it came about.
But it does sound from what you've said, though, that the body having been created with the very particular structure that was adopted, and it's not really right to say that because you've got a company given by guarantee, you must have members. I mean, of course you must have members if you're a company limited by guarantee, but that doesn't really explain who the individual members are that have been chosen. And it does look as though once this body has been created, it's more or less been these members deciding which direction these members want to take, with the Commonwealth not being, as it were, taking ownership of what has emerged. Is that a fair statement?
That's not my understanding, but I accept your point.
Back to you, Mr. Rosen.
Thank you, Commissioner. I wonder if I could just try and bring it closer to this issue, and put this proposition to you. The corporate arrangement, the corporate status that was settled upon, the company limited by guarantee, is merely that. It's giving effect to the advice from Miles Morgan about the most appropriate legal structure for the council, but it doesn't alter the initial intention, which was the council established to give effect to Strategic Action 14.
That's correct.
All right, thank you. Now, I was asking you about some discussions recorded in the minutes, and I want to just conclude that by asking you about the minutes that appear behind tab 140 in the general tender bundle at page .0019. I'm going to just clarify, this was a meeting that you were present at, yes. We could see that you were there. This is the meeting on the 15th of August 2019. And we see under the heading Matters for Decision a series of dot points, the first one of which records recent discussions between the department and the chair, and at that time that was still Mr Hardy, is that right, Mr McCoy?
Yes.
And LG, is that Mr Gunaratnam of Miles Morgan?
Yes.
Discussions between those two and the department indicated that the department was not going to allocate the minister's pre-election announcement of funding the council for $2.6 million. Do you see that recorded there?
Yes.
And do you recall that being raised at the meeting in August?
Yes.
And just for a bit of context here, the minister's pre-election announcement is, of course, a reference to the previous minister, Mr White.
Yes.
And, of course, post-election, we, by this time, had a new minister, Mr Colbeck, is that right? Yes. And What was the response of the council to being informed that the new minister, that the department was not going to allocate Mr Wyatt's pre-election announcement of funding $2.6 million?
My recollection of the discussion was the council, some were minded to approach the minister directly.
Yes.
Others were more we should keep working with the Department of Health and seek clarity on exactly what the position is.
Can I, and what was the ultimate decision?
To seek clarity from the department. Yes.
And has clarity been sought from the department since that time?
Well, that's an ongoing process.
Just remaining in that list of matters for decision, if I could ask you about the fifth dot point, the one that starts, there was discussion about whether to engage. That could just be highlighted. There was discussion about whether to engage with the minister on the funding issue. A number of directors already met with the minister in relation to their specific aged care issues. Feedback from those meeting was that the minister did not necessarily agree with the commitments on aged care from the previous minister. The minister was aware of the council but thought it had started in January 2019 and had not done much. This misinformation was apparently supplied by the department. Whose characterisation was it that that was misinformation?
I can't recall who specifically said that.
It's quite strong. Sorry.
I personally haven't met the minister.
Sorry, you.
I personally haven't met the minister.
No, I'm more interested in the goings-on at the council, though. I mean, the use of misinformation is quite strong language, isn't it, Mr McCoy?
Yes.
Does it reflect a concern in the council that the department is not properly briefing the minister, the new minister?
Yes.
The minutes then go on to record that it's critical to have the minister on side, and I take it you'd agree with that proposition. And then if we can go over to page .0023, there's an item 4.6.2 at the bottom of the page. I'll just see if I can understand this. The item is listed as Department of Health First Assistant Secretaries Charles Wan and Jay Smith. What does that mean, having that as an item in the minutes? Can you help us with that?
We have a standing... When we established the council, we set up a standing item for the department to dial in or to participate in the meeting.
I see. And then the details that are recorded there is the departmental representatives declined the invitation to attend the council meeting.
Yes.
Was a reason given for declining?
Not that I'm aware of.
So the references to misinformation and the minister not being committed to the previous minister's financial commitments, the department declining to attend a meeting, I suggest to you that taken together, they would suggest a lack of commitment by the Commonwealth to this process. Do you have a comment to make about that?
I understand your point. I think I'm a bit more optimistic. I think it's part of just the formation of the council, getting organised, reaching out to the various stakeholders, and starting to build cadence and momentum around the work we're doing.
Since you've become chair of the council, have you had a telephone conversation with Mr Wan from the department?
No.
I ask you that because Mr Wan is the representative of the department who's been identified to come and give evidence to us on Friday.
Yes.
about the relationship between the department and the council.
Yes.
You understand that?
I understand that,
Yes.
and I have a meeting scheduled with Mr. Wan, I understand, for the 8th of November.
Okay. Can I ask when that arrangement was made?
Would have been on Thursday or Friday last week.
We, of course, don't have the benefit of the minutes from your last meeting last week. I take it they're probably still being prepared, are they?
Yes.
Are you able to shed any further light on the relationship with the Commonwealth based on the discussions at that meeting?
Kate McCauley dialed into the meeting,
Yes.
and we had a discussion around her on the job of work and the prioritisation of the recommendations, and we said that we almost had those in order, and we would be approaching Charles with the schedule of work for the next 3 years, with a recommendation on the level of sort of operational support we think the council needs.
Just before leaving this topic of the Commonwealth and funding, just want to draw your attention to what you say at paragraph 68 of your statement. At the top of page 11, you say, otherwise the council is acting with no funding and other than as set out above, and it does not have any insight into when funding is expected. The council will need government funding support, particularly in the early years, to drive the changes recommended in the task force report with the speed required by the sector. So returning to the question you were asked by Commissioner Briggs earlier, it's the case, isn't it, that without that injection of funding soon, there's going to be a real practical difficulty with achieving the pretty ambitious timeframes that are set out in the Polaires report.
That's correct.
From your dealings with Ms McCauley, do you think the government is of like mind in relation to that? In other words, do you think there's a sense of urgency on the part of the Commonwealth?
That's a difficult question to answer.
Now, I just want to ask you about a couple of the strategic actions, and if I could refer you to paragraph 58 of your statement on page 9. You note the grouping of the strategic actions into those 5 subgroups, and then you, at 59, you say the following strategic actions have begun to be implemented since the release of the strategy in September 2018. If we can just take 3 for the moment, which is going to be the subject of some evidence later this afternoon, reframing the qualification and skills framework, addressing current and future competencies, and 4, defining new career pathways. Can you just briefly indicate to us what work has been done in relation to those?
So, for example, under 3, my understanding is the IRC is looking at getting dementia as mandatory as part of the accreditation program.
The IRC, that's the Industry Reference Committee. Yes. That's the other body that emerges from the Polaires report, which we're going to be hearing about this afternoon. What sort of liaison arrangements are there between you and the IRC?
So I personally haven't had any dealings with the IRC. Previously, Ian Hardy was both chair of the IRC and interim chair of the Workforce Council.
Yes.
So under the new arrangements, I'll have to connect with the deputy chair of the IRC and work out how we work going forward.
Yeah. I should say, in fairness to you, Mr McCloy, we accept that you've only very recently taken over as chairman of the council. The last matter I want to ask you about is strategic action number 1, which is the one about the social change campaign around ageing and aged care.
Yes.
And Mr Polaires gave some evidence about that earlier as being a very important overarching piece of work that needs to be done. It's obviously an ambitious action, and I'm just wondering what the present thinking is at the council, as far as you're aware, of giving effect to Strategic Action 1. Or alternatively, you may say that's a rely for the government, or I don't want to leave that open-ended for you.
So in the way the task force put together the recommendations, Strategic Action 1 we would see as predominantly government-led. It's a countrywide program we need to do to lift the perception of aged care and what it's like working in aged care.
Yes. And at the risk of becoming a repetitive questioner, what indication have you had from the Commonwealth, if any, about its attitude to Strategic Action number 1?
I've had no feedback from them on progress with Strategic Action 1.
Or, for that matter, on any of the other actions that are the responsibility of the Commonwealth, I take it?
No.
Commissioners, they're the questions that I have for Mr McCoy.
Yes, thank you, Mr Rosen. You're free to go.
Thank you.
Just before Mr McCoy
Yes, Mr McCoy, just one moment.
Commissioner, my learned friend wishes briefly to put some factual matters to the witness. I have no opposition to that. Most efficient way might be if it's just done.
Yes, yes, Commissioners are content with that.
Thank you, Commissioners. Mr McCoy, I understand you've been in this role for 1 month. Is that correct?
That's correct.
Excuse me. And so, to the extent that Mr Wan or anyone else from the Department of Health has had conversations with your predecessor, the interim chair, you may not be aware of those conversations. Is that right?
That's correct.
Including organising the meeting for the 8th of November. Is that correct?
Yes.
In your statement at paragraph 52, you refer to your understanding of the government's lack of action on several of the action items. Do you recall that paragraph?
Call it up. Sorry, was it 52?
It's on the screen if you'd like to look at the screen.
Yeah. Yes.
Is it right that one of those strategic actions is Strategic Action 10, which relates to the improved training and recruitment practices for the Australian government aged care workforce?
Yes.
And are you aware of the announcement in the 2018-2019 budget of $14.8 million to fund training for part of the government workforce?
Yes, I was aware of it.
Would you agree that that does appear to be some action in relation to Strategic Action 10?
Yes.
And would you agree that, given your position as external to the government, you have a limited visibility to decisions within government that are occurring in relation to any strategic action, any of the strategic actions the government is taking action on?
That's correct.
No further questions, Commissioner.
Thank you, Ms Morgan. Thank you. You may go now. Thank you very much.
Thank you.
Thank you, Commissioners.
Mr Bolster.
I appear in relation to the VET panel, and there are 3 witnesses in that panel. And the first of those, if I could call...
Can I just announce appearance, Paul, first?
Yes, there is an appearance.
Thanks, Paul. The Commission, please, I
announce an appearance for the Australian Nursing and Midwifery Federation. Mr Robert Bonner is giving evidence today and Wednesday, and Mr Paul Gilbert, who will be giving evidence on Wednesday. And with the Commission's permission, I don't intend to remain at the bar table at all times, but only for particular periods.
We can cope with your absence.
Thank you. The Commission, please.
Barely. Commissioners, I call firstly Jane Leanne Williams, who is known professionally as Jane Truen, who is seated on the right-hand side of the panel.
Please repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence that I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
The next witness immediately to Ms Truen's right is Mr Robert Bonner.
Repeat after me. I solemnly and sincerely
I solemnly and sincerely
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but
and
the
nothing
truth.
but the truth.
And the final witness is Michelle Eastman.
I solemnly and sincerely
I solemnly and sincerely
declare and affirm
that
the evidence I shall give
the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If you could please have a seat. We might deal firstly with Ms Truen's statement. If you have a look at the screen in front of you, there'll be a document that will appear. It's WIT 0482 000 1001. Can you see that?
Yes,
That's your statement?
yes, that is.
Do you wish to make any amendments to the statement?
No,
And are its contents true and correct to the best of your knowledge and belief?
yes, it is.
I tender Ms Truen's statement, Commissioners.
Yes, the statement of Ms Truen dated the 9th of October 2019 will exhibit 11-5.
Mr Bonner, your statement should appear in front of you. Is that your statement?
It is?
Do you wish to make any amendments to it?
No.
Are its contents true and correct to the best of your knowledge and belief?
They are.
I tender Mr Bonner's statement, Commissioners.
The statement of Mr Robert Bonner dated the 24th of September 2019, exhibit 11-6.
Finally, Ms Eastman, you should see your statement on that screen.
Yes,
And that's your statement.
yes it is.
And do you wish to make any amendments to it?
No, thank you.
And are its contents true and correct to the best of your knowledge and belief?
Yes, they are.
I tender Ms Eastman's statement, Commissioners.
Yes, a statement by Michelle Eastman dated the 8th of October 2019, exhibit 11-7.
I might start with a question to you, Mr Bonner, in light of the evidence that we just heard from Mr McCoy, who chairs a fairly similar panel or committee to the Aged Services Industry Reference Committee that you are the acting chair of. What has been your experience of dealing with the Commonwealth whilst you have been the acting chair of that committee?
The Commonwealth has sent a representative from the skills area to each of the meetings of the Industry Reference Committee and remains engaged with us in terms of receiving reports from Skills IQ, the skills service organisation that supports the committee, on a fairly regular basis. There has not been, until a few weeks ago, any request from the Department of Health and Ageing for a formal report from Skills IQ or from the Industry Reference Committee for an update.
All right, we'll get to the work of the committee in due course. Are there any funding issues along the lines of those that we heard evidence about before you were sworn in with your committee?
No, our committee is funded for a 3-year program from the skills area, and we are negotiating for some additional money that I've heard informally has been approved for the work for the next 12 months.
we might turn to vet. Ms Trewin, let's start with you. You're the Executive Director, Educational Delivery of the Box Hill Institute.
That's correct.
And Box Hill is a technical and further education institution in Victoria.
Yes.
And could you give us an indication of the sorts of vet courses that are offered by Box Hill when it comes to the aged care sector?
The aged care sector. Yes, we have a variety of courses from the health training package. We do Certificate 3 in individual support. We have Certificate 4 in ageing on scope as well. And we also have some aged care units in our Diploma of Nursing qualification.
All right.
As well, we have the allied health courses, but they're sort of to the side a little bit with...
And on the allied health, are we talking about physiotherapy?
Yes, not to that level, but the low-level Certificate 3 and 4.
Right. Ms Eastman, you are the Executive Director for Pathways and Vocational Educations, or PAVE,
Yes,
at the Swinburne University of Technology.
correct.
And does Swinburne offer complementary courses to those that are offered at Box Hill?
Yes, we would offer the Certificate 3 in individual support work. We don't offer the Certificate 4 in aged care. We offer the Certificate 4 allied health assistant, Diploma of Nursing, and then in our higher education component of the university, we have physiotherapy, occupational therapy, and Bachelor of Nursing.
Let me ask you about your Diploma of Nursing course. Does that lead to someone becoming a registered nurse, or does that lead them to becoming an enrolled nurse?
An enrolled nurse.
And how many hours of study are involved in that course?
In the Diploma of Nursing
Yes.
course? I can't answer that off the top of my head, I'm sorry. That would be, my specialist would be able to answer that.
Okay.
It's about
It's
700.
1,700 nominal hours.
Yes.
Now, Mr Bonner, your organisation is slightly different. The work that you do in the training sense, you are involved with the Australian Nurses and Midwives Association South Australian branch, and they run an RTO that delivers vet in South Australia.
Yes, and we're just taking on responsibility for delivery in Tasmania.
Yeah.
So we offer programs from Certificate 3 in individual support aged care specialisation at both vet in schools programs for adult learners through traineeship modalities, and then into the Diploma of Nursing and the Advanced Diploma of Nursing.
Could you give us a description of the way in which the course that operates via the school system works? At what age do people come into that course, and what sort of engagement do they have on a practical level in residential or in home care?
So the students enter the program usually in Year 11 as part of their SACE program in the state, so their highest school certificate, and spend 2 years enrolled in the program. They spend a day a week either attending the registered training organisation and completing the academic learning, or one of our educators visits the school and delivers it within the school environment. As part of that, they also have a direct work placement over the 2 years where they complete the practical work in a workplace environment in aged care facilities.
All right. Could I ask a philosophical question to start the discussion? The consumers of vet in aged care, who are they? Is it the student who is funded by the government to study at your institution? Is it their future employer? Or is it the person who is in aged care who's going to receive, at the end of the day, safe, quality care from them?
All of the above, really.
All of those and some other stakeholders, I would suggest as well. So, but in particular, for this context, it would be the clients receiving aged care, ensuring the graduates have the outcomes that they need to provide that care, the students themselves, that we're delivering on the promise of quality vocational education, and the employers and industry stakeholders who employ those graduates.
Mr Bonner, do you have a perspective about that?
I think that at training delivery level, that I'd agree with the assessment that there are student stakeholders, there are employer stakeholders and funding stakeholders that we're seeking to do. But there's also the VET system development level of the qualification design training package work, which is predominantly then what does industry need to meet future workforce requirements. Industry be broadly defined as both employees and employers. So they're the primary stakeholders at that level of the process.
And one of the outcomes of the Polaires report has been the establishment of your industry reference committee. Both you and Ms Eastman are on that committee, correct?
Yes, that's right.
And just in a broad sense, what are you focusing on in addressing those sorts of issues on the committee side?
Well, as I think I said out in my statement, the first part of this year, or really up until now, we've been largely focused on what was given to us as our priority piece of work, which was looking at the adequacy of the existing Certificate 3 and individual support work for Cert 3 performance in the industry. So we've been engaged in a rewrite of that qualification, testing it in its first phase with industry, getting feedback, and just last week issued to the Industry Reference Committee a Stage 2 qualification design for sign-off to go back out for validation. We're now turning our minds to the next stages of work, which is the broader adequacy of training and qualifications in the sector. And so we've set up some work in terms of pathways that both Mish and I are involved in. So looking at future work pathways, education pathways, and also establishing the nutrition and mealtime experience group in addressing that area that's already been ventilated before the Commission in the past.
Why has there been a priority for Cert 3? Why is that a priority?
The feedback from industry was that it was not adequately preparing workers for job-ready roles in the sector. And so that was the kind of feedback that came through the task force. And so we were given that as our priority piece of work, because if that wasn't successful, then there was the fundamental breakdown in terms of work capacity in the sector.
Well, let's talk about the course then, and then we'll talk about the future of it. Mm-hmm. What does Cert 3 attempt to do? What from the perspective of a trainer, what are you trying to achieve when you offer Cert 3 to the hundreds of young Australians who come and study it every year?
So understanding there's the Australian Qualification Framework, which clearly articulates outcomes against qualification levels. Cert 3 would be a base level worker, and in this context to work in providing components of care under supervision to stakeholders within the aged care industry. Some of that care might be in a residential aged care setting, others would be in a community-based or home-based care environment. And they have very strict scope of practice requirements for graduates at that Certificate 3 level around decision making and identification and troubleshooting, problem solving.
Isn't Cert 3 a much broader certificate that can be applied in childcare, in hospital care, and in other contexts?
Not the Certificate 3 individual support worker qualification. So there are a range of Certificate 3s in vocational education, but specifically for this industry, it's a Certificate 3 individual support worker. And then there are components of that are disability sector, home support and aged care. There's three possible specialisation streams.
All right.
That is mainly as a support role in the environment rather than making decisions themselves. So it's actually seen as support.
You may have seen some of the evidence that the Commission's heard over the course of this year about how personal care workers are becoming the largest component of the delivery of care, and they're doing it to an ever-increasing number of people with greater acuity. Is the Certificate 3 that's in place today keeping up with those needs?
No.
I would argue that it's not, and nor is it possible for it to do that, given the kinds of changes in complexity and demand that we are seeing in the resident profiles in our facilities. So I think that we're preparing workers at Cert 3 level for roles that are requiring skills, knowledge and competence that are far beyond that.
The Certificate 3 was never intended, nor could it be intended, to provide solutions to all of those complex problems. It's to be part of a multidisciplinary team working with Certificate 4 level graduates, with diploma graduates, with degree and master's qualified graduates. And I think some of the evidence that you referred to, and I haven't kept up with everything, but the nature of that expanding role and expectation of a Certificate 3 level worker is incongruent with what a Certificate 3 level worker can do.
If I can add to that, I think the Certificate 3 students, when they're on placement, they're involved, more with patients that are people in aged care facilities with dementia or palliative care, that type of role, and they don't have those skills to deal with it in some stages. So they've got more exposure to that, so they really need to be skilled up a bit higher to be able to cope with that better.
The question that I think is a little unclear is the degree to which they're upskilled. Can we turn people that do Cert 3 into nurses?
Into a nurse if you don't invest in the qualification and pay them accordingly and give them the skills, knowledge and experience to be able to do that. So Certificate 3 workers operate within the framework of what they are prepared for and are employed on Certificate 3 level pay.
I think that the problem with the way the question takes us is you can keep on adding more and more content into a Certificate 3 level program. So you can add Certificate 3 level knowledge in relation to palliation or dementia or behavioural care, but it doesn't add to the capacity of the worker to assess independently of other people, to have the knowledge and skills to make the decisions about whether or not it's appropriate to medicate or not medicate a client. So that's the levelling issue that Mish was talking about at Certificate 3. So that's why we need to build pathways that take people up that knowledge tree and capacity tree, as well as broadening skills across the workforce.
I think verticality and horizontality, could you explain to us what you mean by those things? So horizontally, the worker...
So horizontally, you can add on more and more units. So someone who's got a support worker role, qualification-based grade, is now going to work in dementia care specifically. And they can add other elective units onto their base qualification that add to their capacity to work in dementia care. But it doesn't increase their decision-making capacity, their degree to work autonomously, because their knowledge set is just expanded by a further sort of what I describe as horizontal skill level. By vertical, I'm talking about someone who is entering the workforce at support worker Certificate 3, going into allied health assistance at Certificate 4, or enrolled nursing in the diploma stream, or into the diversional therapy stream. So what they're doing is building on their base skills, but also learning how to take more of a high-level competency set and knowledge set into that work. And I think that there's a tension between what you can do with a Cert 3 and not addressing the fundamentals of the skills mix in the workplace.
Well, the statistics would seem to suggest that a nursing role is being forced on these people that will never have the skills, and there's never any scope for them to be skilled as nurses. Is that a fair summary?
Yes. And classic of that one's medications.
Yes.
And so let's medication credential people in support worker roles, but let's not give them the knowledge in anatomy and physiology, the interaction of the pharmacy with the body systems, why you might withhold on the way through. So you can teach medication, but if you don't broaden the overall capacity of the individual, it's still not safe.
What about, for example, maybe topical with some evidence we'll hear this week, what about wound care? Is that...
So a Certificate 3 level worker hasn't got the deep understanding of physiology and assessment and impact to be able to make decisions about whether wound care is improving or not improving.
Well, are they trained to carry it out?
No. They're trained to notice changes in skin condition and skin breakdown.
Yeah.
That should then be reported to the registered nurse for investigation and for care planning when that occurs. But you couldn't possibly talk the level of knowledge and skills you need to in terms of selecting the appropriate treatment for a wound
Is it possible for you to sit a little closer to the microphone? It's quite hard to hear.
Sorry.
But fundamentally, you're saying you can pick up basically entry-level skills that you need as a support worker to other more professional staff, but you need to be trained at a higher level to bring the knowledge that's needed at that level to apply particular higher level skills.
Yes.
Is that right?
That's correct, Commissioner. I mean, if you don't have assessment, planning skills, the kind of technical knowledge and skills, then it can be dangerous to ask workers with a Certificate 3 level qualification to cast their practice into those areas without supervision and support.
Yes.
Now, you mentioned that you've been, in your statement, Mr Bonner, that you've been involved in a consultation process with industry about the development or the changes to the curriculum for Cert 3. Can you tell us what that has involved?
Yes, the Industry Reference Committee looked at the design of the individual support worker qualification as it applies to the aged care specialisation, and we were concerned really about the degree to which it was possible for RTOs to select, registered training organisations I should say, to select from a pretty vast menu of electives. And the advice we were having was that sometimes those elective choices were being driven by cost and delivery modality rather than by what the best needs of the student and industry were. So we recast the qualification, and the biggest single change we made was to reduce the electives to a much shorter list that were directly applicable to working with the aged.
And how many electives are we talking about?
There are 3 in that group, and there are 3 that are required for aged care specialisation.
And they are?
Here's my carefully prepared note for Commissioner.
Hang on, there's got a new version there, and that's existing.
Yes. So the core units are still provide individual support, independence and wellbeing, communicate and work in health and community services, working with diverse people, work ethically and illegally, recognising healthy body systems, follow safe work practices for direct client care. So they're the core units that cut across all 3 areas. The ageing specialisation, facilitating the empowerment of older people, providing support to people living with dementia, and meeting personal support roles. All right. So they're unchanged fundamentally in terms of the revamped qualification.
Where did the direction in your consultation process come from? Did it come from the employers of these people, or did it come from other RTOs, or did it come from industry generally?
The draft qualification went out to industry broadly. So we sent it out, it was on the website, we held workshops with industry and training providers across the country, and we cast the net far and wide in terms of going through the industry peak organisations, writing to all the stakeholders, seeking their consideration and feedback.
And what was the response from industry, from the actual employers? How useful was that?
In the end, we had, I think it was 280
Yep.
is the approximate number of responses to the draft qualification, and over 200 of those came from training providers rather than from employers.
So only 80?
Less than
employers.
80.
What about the peaks in the industry, so Laser and AXA?
I can't remember whether or not they wrote separate submissions, but certainly their members did. And of course, our Industry Reference Committee has representatives from each of those peaks on it, and so they gave direct feedback in relation to their members.
Professor Pelaez said a couple of things this morning in his evidence. He talked about the aged care industry as yet to define itself and needing to establish a purpose. Do you see that issue resonating in industry involvement, engagement with the development of training programs for its workers?
Yes, that's a very broad kind of question, I guess. we have experiences as Swinburne and also of the IRC of working with particular stakeholders who are actively involved in trying to shape what their workforce of the future looks like. However, the sector as a whole has, you know, a broad-ranging remit as to how we support an ageing Australian population, and I think has landed on a model to date that is now a hotel experience model and has precipitated things including 40% of residents of aged care facilities having markers, you know, acute markers of depression, loneliness, isolation. So if the industry is to define itself, then the proposition around that is actually, as a society and as a community, how do we value people in an ageing process, and how does that then become part of the narrative for our graduates? Specifically in vet, we are being driven to produce graduates who are focused on tasks and doing things as certificate 3-level workers. In its purest form, it should be under guidance and direction, and then once they're reaching employment status, it's becoming an ever-increasing scope of what's expected of a entry-level worker.
And I think it's like most industries, really. You have your really good RTOs, you have your really good industry that are very proactive, very innovative in their thinking, doing the right thing. So the ones that have got it right are making great progress and doing some things, but it's not across the sector as a whole. So from our perspective with our students, when we're setting them out on practical placement, we want to make sure that they're very highly skilled skilled up to know what they're going to be facing, and then very tightly monitored. But that relationship with our partners in the sector and knowing what they're doing in their space is really important. And we try to align with the ones that are really proactive and then try and influence the ones that aren't so proactive.
And to what extent are people proactive and not proactive?
I think the standard of care.
I think that our experience as an IRC, and certainly our experience as a training provider, is that industry has to be engaged by us rather than industry seeking to engage with us.
Yeah.
Why is that?
I think that the language of the vet system and the training system is alien to most industries, and the aged care as an industry that's still in many ways sort of suffering from cottage industry features is even more isolated than some others. So I think some of the engagement tends to be, even when they do engage, from training managers and workforce managers rather than directors of care or CEOs that you might get in other industries. So you tend to get pretty transactional conversations rather than meaningful stuff about what they would be seeking to get from workers into the future.
Ms Eastman, what Swinburne's experience?
I would say there's also an overlay of economic drivers. So the partners of choice who we would partner with are interested in understanding quality experience for their clients and quality graduates contributing to that. Those who we then may have a transactional conversation with but not a deeper relationship as a training partner appear to have their decision-making driven by economics around what's going to be the cheapest and most beneficial way for them to employ people and or to provide care.
There must be another level of provider out there that doesn't take any of your students or any students at all.
Absolutely.
Absolutely.
What's the... How do you engage with them on your IRC? What's your message to them?
We do that by our skills service organisation going out into some of those areas and seeking to actively interview and engage directly with them. But it can be difficult. So we do as much as we can, but I mean, it's part of the challenge of developing qualifications in a sector that's got, 2,000 or 3,000 providers spread across the length and breadth of the country, as opposed to developing a qualification for submarine design when you have to deal with 1 or 2 providers all located in Adelaide. So it raises challenges.
you mentioned diversity as being a real problem for industry engagement, both in terms of the size, the small, the very many small, as opposed as well as their geographical.
Rural remote areas have quite different capacities in terms of attraction and retention, and also availability of training providers closer to their locations.
And employment surety of our graduates as well. So many Certificate 3 level workers will be employed as casual workers for a variety of providers, and they will cross between the aged care industry and the disability sector often. And the more geographically dispersed that is, so as soon as you start to move away from metro areas into regional areas or from institute-based care into community and home care, then that mix of worker changes.
Yes. Do you have remote placements for any of your students?
Yes.
Where do you?
Well, we're based in Box Hill, and our placement can be as far away as the Western Districts down Warrnambool Way.
Yeah.
We have country hospital placements and country healthcare placements for our students in the diploma.
Are they regular placements year on, year out with existing providers?
Yes. Yeah, we have agreements.
And in the course that we're about to commence targeting Indigenous students in the Cert 3 program, we're looking at having work placements in the APY lands, the north of the state, in the Riverland and the like, so that we can actually reach out to placements in country.
Mr. Bonner, at paragraph 68 of your statement, you say in the last sentence, apart from brief periods of relatively small co-investment through mechanisms such as the Productivity Places program and its successors, the aged care sector has used public funding without significant investment of its own.
Yes.
Could you explain what was the Productivity Places program? Why was it a good idea?
The Commonwealth in those programs made available training money targeted to particular industry based on cases that were put up by industry for skills in demand. As part of that, there needed to be industry contributions to the training, and they needed to be cash, not just in-kind investments for the first time. And in that way, the Commonwealth and state funding that was made available was spread further because of leveraging off of the industry investments. In some industries, like mining, that reached as high a leverage as 150%. In aged care, we were able to get up to about 30% co-funding through those programs. Since those programs have gone back to traditional allocation, that money or investment from the providers has virtually evaporated.
So, in terms of the courses that you run, the Cert 3 courses that provide the vast bulk of the employees of industry, what's your experience of industry investment in that process?
None.
As a state
as far
fund.
as financial investment, no.
And
state funded.
State and Commonwealth funding.
And Commonwealth.
And any gaps that are in there are met by the students.
looking forward to the replacement of Cert 3, whatever that may be in 5 years' time, that is fit for purpose, what would a best case approach to funding of that sort of course, and include in that engagement with industry? What does that look like? What does the Apollo 11 design look like?
Yeah, so certainly from my lens, it would be about a workforce that is far more interprofessional and connected, so that the Cert 3 worker alone is not bearing much of the burden of care provision in a decreasing cycle of supervision and guidance, and that there is a greater blend of Certificate 3, 4 and diploma level workers across, and I'm not trying to make a nursing workforce as a non-practicing nurse, it needs to include allied health and a range of leisure and lifestyle and stimulating activities. I think there is room for us to look at the introduction to this sector of things like an apprenticeship model, but for that to occur, it requires a radically different funding and economic levers and buy-in and participation financially from providers themselves, and a rethinking around what that experience looks like. So
Why
apprenticeship? Because there's status and recognition from employers and from government around apprenticeship versus traineeship. There's a social value on the premise of an apprenticeship model as opposed to a traineeship model. I think traineeships at scale have suffered from poor reputation and from being exploited in some of the known experiences nationally.
Traineeships are fundamentally a funding vehicle. There is no learning model associated with traineeships. Apprenticeships have a specific learning model which applies both workplace learning alongside institutional learning, leading to a vocational outcome. So I think that's what I would argue to be the fundamental difference between the two, and we need more of an apprenticeship-focused model than just funneling money for training.
And from our perspective, when you look at the Certificate 3, it is a support role.
Yes.
If you look at classic Certificate 3 apprenticeships in other industries, it's not a support role, they're actually a qualified practitioner. Yeah. So we're actually, and they can give direction as well, rather than just having to support people.
Give an example to bear that
well,
out.
if you look at a hairdresser or a plumber or something, they can actually do the work themselves without being supervised once they've completed their apprenticeship. So with the traineeship, it's generally in the workplace. A lot of times with apprenticeships, it's a mix, like you said before, but also it does hold a lot more credibility than traineeships in the view of industry's eyes. And I agree. I think, I mentioned slightly before, palliative care and dementia is becoming more and more visible and stronger where they've got accessible. So we would really look to see those sort of skills involved. We've had the situation where ideally we'd like to have our students coming in at Cert 3 and pathwaying up into the Cert 4 in ageing, but actually they've been employed straight away in Cert 3 and stopped from that further education. But a lot of the skills that are in the Cert 4 ageing is actually what they almost need in the Cert 3. So it's sort of a little bit of a kind of backwards. And so it's levelling and straightening it out to make the skills relevant to a real Cert 3. So even dropping the word support could end up, if you put the right skill base in that qual.
The other part of the vision that I would add for the 5 years' time is the modular approach to skills development. So actually making it easy for people to enter at a Cert 3 level, grow their skills into the Diploma of Nursing, into the Cert 4 in allied health support, into diversional support and the like, in a way that doesn't force them to restudy, get RPL, go through all those complicated processes that cost time and money and put people off doing them.
And there is the opportunity to upskilling and reskilling the existing workers. And if the businesses actually have the opportunity with skill sets, micro-credentials, badging, whatever you like to call it, they're all very similar, there is an opportunity to get the diversity, when we're talking about the leisure and health and activities, get the patients out of bed and into the room and more active and things like that. But it's actually giving these Cert 3 students opportunities to add to their portfolio of skills.
The difference I would have with that was the caveat I said at the beginning about broadening rather than deepening skills. So skill sets are useful to supplement and broaden capacity for knowledge at a particular level. They're not a substitute for improving the qualification base for the broader role.
Might I ask a series of dummies questions? Because I don't have a background in education and I do try to understand it. How often does the IRC update skills and qualifications in each of these things? Is it 5 yearly, 10 yearly?
Not any longer, Commissioner. So that there was an expectation under the previous system that all qualifications would be reviewed on a 5-year cycle.
That's what I thought.
Now there's an annual rolling process for industry reference committees to submit cases for change to the Australian Industry and Skills Committee to approve funding. So
that's good. So in your evidence earlier on, I might have misheard you or misunderstood the lead-in, but I checked the running write-up of it. It sounded like, even though you'd said dementia should be a core unit, that it wasn't actually still a core unit.
No, it is.
It is now.
It is, absolutely.
When did that start?
It has been a core unit for a few years.
But I thought it was an elective unit.
It's called an elective, but it's mandatory if the person is to qualify for individual support specialising in aged care.
Okay,
So
so
there are
the
two
three electives that you mentioned, are they all mandatory?
Yes, so the three electives that I mentioned, if the aged care specialisation, so facilitating empowerment, dementia and personal support, are all compulsory for the aged care specialisation.
The next point that I think you made, Ms Truen, is that in other sectors or other industries, Cert 3 certification, traineeships, whatever, is more than an entry-level grading. It enables people to operate independently to some extent.
That's correct.
Now, why is a Cert 3 in aged care less adequate than a Cert 3 in another industry?
Good question. And and that's when, especially you look at the apprenticeship level Cert 3s.
Yes.
They do end up, when they get their qualification, they are a standalone qualified practitioner for that industry and they can work on their own. When you have a Certificate 3 in individual support, you will always be a support person.
So it's the difference between a Cert 3 where there is apprenticeship involved at the end. No, it's not. Can you explain that? I can see both.
Mitch and I are sort of sitting here saying, have we got the AQF in our pocket? And we're neither of us.
Yeah.
So the Australian Qualifications Framework specify features of vocational performance at each level of the qualification. So Certificate 2, Certificate 3, diploma, etc. And they are constant across all qualifications, regardless of which industry they're in or how they're delivered. So the issue is about the degree to which the worker is required or enabled through their training to make autonomous decisions, to act independently, or whether or not there's a degree of oversight, supervision and the like in there. So they're constantly applied.
So in order to have a Cert 3 become more capable of acquiring the knowledge and applying it, as you were suggesting earlier on, does that mean, Ms Eastman, that there should be more on-the-job training, more classroom training, or what?
Why I specifically use the apprenticeship word was because that's a tripartite relationship between the participant themselves, they're directly employed by the employing organisation, and the training provider as well. So it builds a co-investment in the successful outcome, and it blends the learning. So there is on-the-job component, there is then structured learning for practice in a training organisation environment where you can fail safely, you can learn from that, and then you can be deemed competent to apply those skills back in your workplace, whether that is in aged care or plumbing and bricklaying. So that some of the anomalies that you referred to about why the difference are exactly some of the work that the AQF review with Peter Noonan in particular are looking at. It's been an evolution of time and different industry sectors, and also that many of the traditional trades still have licensed organisations and particular thresholds of demonstration of outcomes at year 1, year 2 and year 3 that need to be met at a state and or national level.
So an apprenticeship in aged care would take longer?
Yes.
Would take 2 to 3 years on average? And would involve both more time in the classroom and more time supervised in the workplace?
And the Commissioner, the word you used was supervised in the workplace, so that is also part of the ingredient as far as adequate staff mix and adequate staff skill to provide guided supervision and development of those skills on the job.
Now to create an apprenticeship environment compared with the range of providers now that provide training Cert 3 level for personal care workers, I'm assuming that the volumes don't match, that there would be many more people who are getting Cert 3 qualifications in aged care as it stands now, versus the challenge of providing an apprenticeship type model for equal numbers of people. Am I right or wrong about that, or is that just a crazy observation?
I think it's an observation of the state at the moment.
Yes.
But I think if I was imagining a 5-year difference, then I think you could get a like for like.
Yeah.
Organisations need to employ care workers. So it's then about the value of the care worker and whether you change the model to be an apprenticeship as an inherent requirement, as opposed to someone who may have achieved their Certificate 3 through a historic delivery.
Okay.
The challenge would be in areas like home care,
Yeah.
where typically one worker goes out on their own. And if you were using an apprenticeship model, that would necessarily mean accompaniment and direct supervision. So those things would add to cost and would need to be met. And there are some times of the day during low shift periods or on weekends in even residential care where those factors would come into play. So the point that's been made about adequacy of supervision and support and practice experience is really important, because the apprentice is there fundamentally as a learner rather than someone who's independently productive during all of that cycle.
Well, that would require considerable change to the aged care industry. I'm sorry I've interrupted
Not at
your
all,
train of
Commissioner, not at all.
questions, Councillor.
Certificate 4, has that fallen by the wayside?
Yes.
Yes.
Why?
Financial imperative. So the drivers for having cohorts of students is that they will achieve employment outcomes that are meaningful at the end of that. And there is a very slim employment demand within the sector itself for certificate level 4 graduates. That's changed over about a 15-year cycle.
I mean, the origins of the Cert 4 were to short-circuit the regulation of the Nurses Board at the time, who was trying to restrict the use of people without appropriate systems of supervision. And so the industry set up the Cert 4 as a way of sort of putting enrolled nurse level skills into an aged care qualification, but not have licensing rules apply to the group. And so that's now run its race. So I would argue that time's caught up with the Cert 4, and instead of reinvesting in that, we actually need to build pathways into full nursing roles rather than recreate that level.
Is a person with a Cert 4 more expensive for a
Yes.
nursing
Yeah.
home? How much more?
It's not vast, but it's a reclassification within the award system, and employers have traditionally wriggled to avoid it.
Is the skill useful?
There's different skills in the Cert 4 to the Cert 3.
Is the Cert 4 the diploma level?
No. Certificate 4 is the diploma's Certificate 5 equivalent qualification in AQF.
So there's a clear progression through them. And what you're telling us is what we've heard in the evidence before us, that the focus in the industry tends to be on Cert 3, and then the workers in the sector aren't necessarily encouraged or feel disinclined to go further.
Correct.
And the excuse we've heard for that is they didn't necessarily do very well at school, so they don't necessarily go much further, or they've got other interests and so on. Now, we've heard that in some places, but not every place, I'd hasten to add. And you're looking very sceptical about that. So let's talk about the aspirations of people in the sector, because this is really important to making this workforce engaged.
Oh, no, I do agree, but there is also a lot of people that are returning to work, or retrenched workers that go into that. But what we find with our students, that when they're out doing their placement, we've got some of our partners give our students guaranteed employment when they finish the Cert 3. So that doesn't encourage them to go on to the Cert 4, because then they've been employed, and the whole idea for them is to get a job outcome at the end of their course.
Yeah, that's a better way of saying it, I think, to get a job outcome rather than to sit there. Okay.
The other piece of the puzzle in this complex land of vocational education is there's a funding disincentive
Yes.
for people to retrain into this industry area if they do have a higher level qualification. So you might be a mother returning to work who might happen to have been a physiotherapist or anything else that has a diploma or higher qualification. If you're wanting to do a personal care worker qualification, you will not be eligible for state government funding in the main to do that.
So
You'll have to pay a fee for service.
If you've had a traineeship in one qualification stream, then you won't get a traineeship to migrate that qualification into another stream. So the funding mechanisms actually get in the way of career progression and people building qualifications. The other thing I'd say, Commissioner, in response to your question, is that there is no single pathway. So some people who might have a Certificate 3 in support work might find themselves moving into a Certificate 4 in diversional therapy rather than a Diploma of Nursing or in some other role within the organisation. So it's about matching the skills and aspirations of the worker and their capability with the jobs that need to be done as a balance, and then giving them additional assistance in terms of numeracy and literacy and some of those issues to get them through. It can be done.
Thank you. Sorry.
Can I ask you about a witness we heard in Sydney? It was a personal care worker who did the Bachelor of Dementia course at the University of Tasmania. And extraordinary evidence was that when she graduated, she came back to her facility, no extra responsibility, no role in management, no decision making. It was just the same job, although she had put considerable period of time and a lot of effort into getting that course. Why isn't that sort of knowledge and that sort of approach valued?
You would need to ask the employers that question, I would suspect. Certainly within an education environment, it's valued, but there's not a proportionate match with the framework of employment within the sector.
And that's what's different to our sector, because the question we always start with is what's the vocational outcome that comes from the program we're seeking to develop and deliver. And in some of those higher ed sector programs, there is no vocational specific outcome. It can just be additional knowledge for interest's sake as the outcome or product from the course.
But the vocational outcomes come from a history of industry engagement and practice.
Precisely.
Hands-on
embedded,
skills.
Roles. Why can't industry get involved and embrace that sort of outcome and give that person a role?
Sometimes it's a lack of understanding by the employer. Like a lot of the vocational sector courses are very much about the hands-on skills, and a lot see the university qualifications as a research-based.
But it's also the cart and the horse argument here. If a university, and I'll leave the specific example to one side, but if a university goes off and devises a course of its own right without engaging with industry as to what the demand is, we can't then expect industry to create jobs just to match the qualification outcomes that a university might do to earn money as a training provider. So it's about how do we make sure that whether it's in vet or in the higher ed sector, that there is engagement between industry and the education providers about the demand so that the graduates can have some assurance that when they do the course there'll be some reward and benefit from doing it.
Could I turn to unless you wanted to say something?
No, no, that's fine.
Turn to the Joyce review and what the implications are for this part of the vet sector. What does the Joyce review say to aged care vet providers?
So I would characterise the Joyce review as yet another example of rearranging the deck chairs of the system. So reframing the governance, reframing who commissions the work, reframing who does the quality assurance without addressing the fundamental problem, which is about what does a qualification look like? Is it compliant with the needs of industry broadly stated now and immediately into the future? And is it producing good quality graduates? So I think that's the fundamental problem I would have with it. The second thing I would say is that the proposal to pilot industry training organisations in the aged care sector and disability sector is just horrendous thought. We are 1 year into a 3-year change process for qualifications for this sector, and government is proposing we start again by a new parallel training organisation taking responsibility for the same area. Why would we continue our work? So we would be saying to government, if you want to pilot this model, do it somewhere else rather than crossing over into an area that has a critical workforce need that we're only just into addressing.
Was your committee consulted about the decision to pilot aged care?
No.
And presumably, if they'd asked, you'd have given the answer you've just given.
The discussion we've had at the committee was that, as I've outlined, that why would you do this? Because it means that the resources we have available will be stripped away in terms of the technical skills available, because it's a small market in terms of writing qualifications for this industry. Those people would be poached by the incoming skills organisation who would have a contract for a longer period. So why would the staff remain with our skills service organisation and complete our work? So we have great trepidation about the overlap. If you want to do it at the end of our period of tenure, and after we've had a chance at fixing up the issues that we've been given a job to do.
Ms. Eastman, do you...
Yeah, similarly, I think perplexing that they've identified this area as a pilot model. There are a range of other industry areas that this could be tested with as far as the service organisation model goes. It's taken establishment of the IRC to build understanding of our purpose, our priorities, get all the stakeholders on board, which are from a broad range of providers of aged care as well as providers of training and consumers. So it would be a drastic duplication and would derail work that is really just getting going with reimagining what the aged care workforce needs.
Is there a dialogue in place to reconsider that decision?
The Commonwealth is currently going through a consultation process, but we need to see whether they're listening, as well as having conversations with us about that. They've not sought to meet with the IRC about the issue. So individual stakeholders have been invited to roundtables, but there's been no direct communication between the federal department involved and the IRC about their proposition.
Who on the part of the department, attends your board meetings?
It's been someone from the Skills Directorate, so typically one of the director level people from within the Skills Directorate. I can't remember the name of the directorate now that it's been remapped in the new government department.
And has this issue been raised as a matter of concern to the committee?
We raised it with them at the last IRC meeting, and they took our concerns on board, and they tried to reassure us that we'd still have a role, but couldn't explain how the two organisations would work alongside one another for the next 2 years and not get in each other's way.
Where does that fit in with the Polaires inquiry action plan? Does it dovetail within any of the actions?
Joint review findings?
Yes.
No. No. I think they're two separate guiding frameworks.
Yeah. We've mapped our role against 3 or 4 of the task force recommendations, and other people have got other parts of the task force recommendations to deal with, but it's not clear at all how many of those would go to the skills organisation as well.
Just while we're on that, in terms of the Polaires recommendations, you mentioned that the committee has effectively been given the opportunity to deal with a number, but not all of the recommendations. To the extent that the committee doesn't engage in that process, who else will take on the responsibility for implementation?
I guess we were lucky for the first 6 months that Ian, who was our chair, was also chair of the Workforce Council, so that we had the same person going between both bodies. That's now being tested because we no longer have that, and so we actually have to establish now formal discussions between our groups to keep things tracked down. But he would advise us that the Workforce Council was dealing with certain things, the department was dealing with others, and we would. So he was our roadmap. So now that he's no longer in play, we'll have to put formal processes in to make sure that we can keep track of who's doing what to whom.
We were very clear, so from my interpretation as a committee member, we were clearly focused on recommendation 3 and 4, and then secondary to that, looking at recommendation 7 and...
And we've narrowed it even then in the last couple of weeks in terms of the career pathways by making it clear that our role in the world is about the education pathways, not about the occupational pathways, because that's effectively an industrial matter to be sorted out between employers and the employees in terms of job roles and what people do and how they're rewarded.
So what's the direction for the education pathways? What is the process that's going to happen in the next 18 months? Where's the direction?
So our special advisory group was just constituted about a month ago. We had our first meeting 2 weeks ago. We expect to have our first discussion paper formulated and ready to get out to industry as the hope by the end of November this year. That starts talking about issues of how can we create that kind of building block approach to skills. How do we make sure that we have the right kind of match between training and job outcomes?
All right. Another report, the ASQA report from 2014, which dealt with quality issues in your industry. It came up with a whole list of recommendations. Could you give the Commission a summary of the key findings of the AXA review?
The ASQA review was really looking at unduly short courses. So they were looking at the sort of add water over the weekend courses in aged care that was leading to really poor results in terms of training and capacity outcomes. The result of that was that just tackling duration of its own, which is one of the recommendations of Joyce, wasn't enough. So we need to look at mode of delivery. So there were some providers doing aged care in remote areas in particular entirely over the net. So no requirement at the time for exposure in the workplace. And clearly that's not an acceptable way forward. Teacher qualifications and capacity, current industry knowledge, those were all input. So the outcome of that review was that committees like ours would have the capacity to make a risk assessment based on what we know the risk to consumers, risk to students and workers, risk to industry reputation, about what additional measures would we put in the training package that would become regulatory in nature, so that ASQA, when they go out and measure the quality of training provided by an RTO, could give attention to those. Presently, those measures are all in the companion volumes of the training package, and they're not enforceable standards. So they can look at them, but they can't require RTOs to comply to those levels.
What has been the Commonwealth's response to that raft of recommendations?
There was a further committee formed to look at training package reform. That was a collaborative exercise between the senior officials network in the state and federal departments of education and some of the industry peaks that created models for how that could be implemented, and it's gone nowhere.
You identify a problem in course development and updating that it involves an ANTA process, which means state and territories get involved, have their say. And that process, how does that impact on the ability of industry to get action in this area, even now?
It's very slow, even now, with our new requirements as the IRC, for example, and having made some recommended changes to what the Certificate 3 level individual support quad will look like. That now has to then go back out around for consultation with all of the state and territory committees and seek advice and validation or not from all of those before it can then go up to the AISC committee. Is that right? Yeah.
It's the Australian Industry
and
Skills
Skills
Committee.
Committee.
And the problem from there is that if any of those state or territory state training authorities run interference against the change, at the ministerial council meeting that follows, that actually gives final approval, if any of those withhold consent, then it goes down. So you have to go through a process of negotiating with industry nationally about what the training qualificational package looks like, and then any of the states or territories can effectively run a right of veto over that content, and you have to try and then moderate it down to get rid of their complaints, or the ministerial council ultimately won't sign off.
So it's months and years, not weeks, to get changes made.
Which is also one of the faults of Joyce, because Joyce doesn't contemplate working in a federal system in the way that we do here. It's using a model from New Zealand that doesn't have the kinds of complexities that a federated environment brings.
Just before I ask you to give your perspectives about how things should change, there's one other topic, a discrete topic, slightly different topic that I'd like to address. Registration of the personal care workforce. What benefits do you see as providers who work with students and people coming into the industry? What benefits could such a scheme have for that career pathway?
I think if you look at sectors that have introduced registration, what it does do is provide a level of oversight and governance that protects the consumers of that service. So I have a history of understanding the registration with regard to the nursing model, but also with regard to licensed builders, licensed plumbers, etc. And I think what it does do is then creates a regulatory environment that at its peak protects the most vulnerable consumers of whatever it might be, and in this case of aged care services.
And it's good to have visibility of currency, so you can actually see when they were last trained, how current their skills are. But in saying that, where we've tried to get regulations into some industries, it's the person who's going to be monitoring those. That's where it falls down a lot of times.
That was my next question.
Oh, sorry.
How would you, as Eastman's mentioned, would the Health Professionals Registration Authority be the way to do this, or should it be done in any other way?
I think there's a model through the APRA model, the Australian Health Professionals Association model, that could look at it. But I'm very mindful, aged care is not a medicalised model, so we need to be consumer-driven and listen to what the stakeholders from a consumer lens are really looking for, because aged care provision is very broad and not institution-based.
I would argue that the fundamental tenet of the professional regulation under the health practitioners scheme is protection of the public, regardless of the domain. We are dealing in this environment with some of the most vulnerable people in care anywhere in the country. So we need a scheme that is fundamentally modelled on the health practitioners law, that is in the interest of protecting the public. And as part of that, you then deal with conduct, you deal with competence, and you deal with qualifications approval. I think what it brings to training delivery is the translation of a training package and competency set into curriculum. And we don't, in training package world, deal with curriculum. So when we turned the Diploma of Nursing training package into a course, we then had to go to ANMAC, the regulatory authority in nursing, and show them how we had interpreted the contents of the training package, the pedagogy, and how we were proposing to deliver that program, that we had the resources and the staff and the capability to deliver it to the appropriate level. And that's missing in the aged care qualification. So regulation in that sort of way would bring that rigour both to the work of the workers, but also to their preparation.
John, did you want to add anything to that?
They've covered that quite well there, but but I really do think it does come back to, the currency and the skills, making sure they've got the right skills to do the job, putting the patient first at every time, at every stage, and looking at, you know, from my perspective, who's doing it well and what are they doing that's different to who's not, and that's from an education perspective to a business, an aged care facility perspective and everything, even to councils working with home care and all that type of thing. So it's quite broad.
Other holders of Cert 3 qualifications would have registration requirements, would they?
Yes, there is, like electrician, building, and nursing.
Childcare.
Yeah,
And complaints mechanisms
Aboriginal
for
workers.
the
Yes.
holders of those qualifications?
yes,
And accountability
Yes.
for their qualification and continuing to hold it?
Correct.
That leads me to the last three questions, one for each of you. What's your vision for this sector? Who wants to go first?
I've got a philosophical vision. I don't know how practical that is, but I think many Australians have watched with joy and sadness the Old People's Home for 4-year-olds model, which is an ABC documentary. And what that exposes is the core tenets of what great aged care looks like and how you can have a multi-layered approach that is intergenerational and interdisciplinary. And that would be my desire for aged care, as we revisit, actually, it's not just about Certificate 3 level workers being supervised by registered nurses. There needs to be a whole workforce, but also an outreach and models of care that are based on true connection with the community, with breaking down isolation and visibility, and then a whole range of factors around elder abuse and depression and isolation get removed because of the physical activities that can be brought into that experience.
I would like to see in a lot of the facilities where they've had a duty nurse and they've got a lot of support workers that are mainly as Certificate 3 students that are actually build up a big percentage of the workforce, actually look at the skill level of what's required for the business and making sure that we're pitching at the right levels of what we're delivering the education to what the right skills are required for the job outcomes. So at the moment it seems to be that and that, but we need to have a really natural progression where, you know, we're skilling up to suit all the different diverse types of aged care requirements that there is for the sector.
Mr. Bonner?
I guess that I'd be arguing that we need to be blending the needs for competent individual workers with a capable overall workforce that blends the various skills and attributes, professional disciplines to meet consumer needs that are ever growing. And so we need more people with more capabilities and knowledge with greater skills at the point of care. To do that, we need to make our qualifications easier to navigate and easier to progress, and we need co-investment and co-responsibility between industry, students and training providers to get there.
I have no further questions, Commissioners.
No.
Well, what a task you've set. I've sat there quietly bemused, and thank you very much. The educational training component of aged care really is very important, and we've learned a great deal this evening, and it's been terrific to hear from three people who are so intimately involved in the training at the coalface. Thank you very much.
Thank you.
Thank you.
Might the witnesses be excused,
Yes,
with the exception of
witness.
Mr. Bonner, who has to come back later in the week to talk about ratios.
You are not excused forever. You're only excused for today, but I think you should be allowed to go home tonight.
That's the evidence for today, Commissioners.
Yes. Thank you, Mr. Bolton. Well,
Let's call it a day.
we'll adjourn until tomorrow morning at 9:15.